strengthen collaborations, and equip us to serve our patients with even greater excellence, compassion, and integrity. We also remember our nation, Ghana. Bless our healthcare system, strengthen all healthcare professionals, and grant wisdom to our leaders as they make decisions that affect the health and well-being of our people. Father, we pray for your protection over everyone gathered here. Let this conference be productive, peaceful, and impactful. May we leave here refreshed, encouraged, and better prepared to fulfill the calling you have placed upon our lives. Finally, Lord, we commit every plan into your hands, trusting that you will direct our paths and crown our efforts with success. We thank you because we know you have heard our prayer. We make this prayer with gratitude and humility. Amen.
Amen. Let me remind you that we are live on most of the social media platforms, so be smiling. Thousands of people are watching you. Now, we ask Unichem Pharmaceuticals to make a presentation. Oh, hold on, Unichem. We invite the president of SPMDP to make a welcome address. Mr. President.
Good morning, senior colleagues, sponsors, supporting staff, ladies and gentlemen. We are here. Another year brings us to our AGM. Once again, I want to thank God for our lives and everything He has done for us. Thank God for traveling mercies here to Ho. So this is the third AGM being organized by the current executive that was elected a few years ago. I have one more year to go. I'm anxiously looking forward to 1 year, so I go on retirement. You know, SPMDP, 2 terms is 2 terms. We don't need Supreme Court to interpret it for us, just by the side. So, colleagues, welcome once again to Ho 45th AGM. The theme is the new dynamics of cancer and its management in attainment of SDGs. So this officially opens the conference. We'll have scientific sessions today, tomorrow, an opening ceremony, and then continue the scientific session. And we are 99% confirmed that the Minister of Health will be with us tomorrow. You can have all the confirmations, everything, but the president can call him at the last minute. But so far as to speak, we are 99% sure that the minister will be with us tomorrow. So welcome once again, and may we have a fruitful conference. Thank you.
Thank you, Mr. President. Unichem, you are invited.
Good morning. So my name is Dr. Kwiku from Unichem Ghana Limited. So I'm here with a team to just give you a refresher, a reminder on our products. So my boss is here, Mr. Negi Chandan. He is the sales and marketing manager of the Tema branch. Yes. So I'm also here with Famaxo, Aisha, Fiona, and Mr. Uti, and the rest of the team. So I'd like to make a presentation, a reminder, a very, very quick reminder on some of our products. So one of our first products is VitaForce. So this particular brand is a sugar-free syrup for your diabetics. If you need a multivitamin for them, this is the perfect multivitamin. It doesn't impact the glycemic levels. There's the tablet. So one unique thing about this product is it's a multivitamin with ginseng. It has ginseng, which helps in the regulation of the blood pressure. It also has lycopene, which is very good for prostate health, and chromium for regulating blood sugars. And we also have Nuvita, which also is a multivitamin that comes with ginseng, just like the VitaForce, but this has more ginseng in it. And it's also very good for your diabetics because it has no sugar. It also boosts energy. It combats stress and also boosts your immunity. Yes, and we also have our range of cough syrups. So we have the lowest baby, lowest children, the children's dry cough, the adults, the chesty, and the nighttime. So with this one, all the forms of coughs, whether dry cough, wet cough, those with allergies, we have all the ranges to fight those particular allergies. And we also have serotonin. This one in particular for your stroke patients, particularly those with ischemic stroke. This has been found to be very, very, very beneficial to them. It acts by enhancing the glutamate pathway, the part that is responsible for cognitive functions, memory, knowledge. So if you have anyone with a neurological deficit, serotonin is the best brand. Piracetam 800 milligrams for Mortarita. And this is marketed by Unichem Ghana Limited. And we also have Lesforin. In this age of antimicrobial resistance, we've come up with a formulation. It contains bacitracin, neomycin, and polymycin D, covering a wide range of microorganisms. So to combat antimicrobial resistance, this is the perfect blend. This is the perfect panacea for antimicrobial resistance. And we also have Gynomycolex. This is one of the few antifungal, which is an antifungal with antimicrobial properties. With this particular pastry, it comes in 400 milligrams, 3 ovules, and very, very soft to insect, which is also good in reducing vulvovaginal candidiasis. And we also have Cipralex TZ, a combination of ciprofloxacin 500 milligrams, which covers both gram-negative, gram-positive, and tinidazole, a very long-acting nitroimidazole. So this particular one, it is used in the management of PID, diarrhea, even dental infections, UTI, a wide variety of infections. And I know there's one of Lewis's legacies, Cipralex TZ, and I know we are familiar with them. And we also have HEMAP injection. So we have our range, 100 milligrams per 5 ml of iron sucrose, HEMAP injection from Cadila Pharmaceuticals, which is marketed by Unichem Ghana. And we also have HEMAP, ferrous sulfate, HEMAP liquid. So in cases of severe anemia, we put them on the injection, we get to a certain level when we transition them successfully to the HEMAP liquid. And we also have Diclofenac Plus. This is a combination of diclofenac, potassium, paracetamol, and chlorhexazone. So one unique thing about this particular product, what separates our analgesic combinations from the rest is that this has diclofenac potassium, 50 milligrams. So those with hypertension, this brand of diclofenac is very good for them because we don't retain sodium, rather we retain the potassium. And we also have paracetamol, 500 milligrams. The combination gives it a very potent synergistic effect. And those with lower back pain, who are usually placed on muscle relaxants, this particular drug, it comes as a combination of 3 medications, like I said, diclofenac potassium, 50 milligrams, paracetamol, 500 milligrams, and chlorhexazone, 250 milligrams. So instead of taking multiple medication, when you take one pill of this, you've taken 3 drugs. And we have our brand of Xifen, fexofenadine. It's a non-sedating antihistamine. So for those with allergic rhinitis, rhinorrhea, any form, you can give this particular brand, fexofenadine. It's non-sedating, and it's been found to have a very fast onset of action. And it's also long-acting, so you only take it once a day, It lasts in a system for up to 24 hours. I think that's all. I think that's all. Thank you very, very much for giving us your attention. We'll be back again. God bless you.
Thank you, Unichem. They'll be mounting a presentation tomorrow, so you see all these products that he's describing. Now, we are going to start our first scientific session. We invite Dr. Benjamin Brew to introduce the chairperson or the chairman for the first scientific session. Dr. Benjamin Brew is the Deputy Secretary of the Central Region. Let's welcome him with an applause.
Good morning. It's an honor for me to present to you the chairman for this first scientific session today. He's in the person of Dr. Omari, who happens to be a long-time member of this association. Please let's welcome Dr. Omari with a clap. Dr. Omari, you're welcome. Thank you.
Good morning. I have the singular honor and gladness and joy to be nominated to chair the first scientific session. Again, with permission from my present executive and our national president, I welcome all of us to this scientific session and to this 45th AGM. Our seasoned presenters are ready, eager to deliver. And we pray that successfully we listen and learn to the benefits of our cherished clients. Thank you.
And so we start with our first presentation. It will be delivered by Dr. Amagani. The profile animation. As she comes, that's your profile. Dr. Gani is a specialist, also a gynae specialist, with a subspecialty in gynecological oncology. And she practices at the University of Ghana Medical Center, the latest Ghana Medical Center in the country. She is a member of both the Ghana College of Physicians and Surgeons and the West African College of Surgeons. She holds an MPhil in gynecological oncology from the University of Cape Town, South Africa, and a certificate in gynecological oncology from the College of Medicine of South Africa. She previously served as the Financial Secretary of the Society of Obs and Gynae, where she contributed to advancing the society's professional and organizational objectives. So she is not new to association like this. She's a passionate advocate of women's health, with particular interest in the prevention, early detection, and management of gynecological cancers. She is actively involved in clinical practice, research, education, and public health advocacy, and has delivered numerous television and radio interviews aimed at raising awareness of women's reproductive health and gynecological cancers in Ghana. So you are in good hands, and I present to you Dr. Ama Gani.
Good morning. Thank you very much for having me. So this morning, my short presentation will be on gynecological malignancies, how to recognize early and how to refer early. Okay, I think this is better. We will all agree that early cancers usually look very ordinary. They have a lot of symptoms and signs in common with a lot of our gynecological problems. So for example, bleeding per vaginum. A patient with polyps or a common uterine fibroids will present with bleeding per vaginum. But it could be from a more sinister cause like cervical cancer. Or a patient could present with an abnormal vaginal discharge, an offensive vaginal discharge. You may think is bacterial vaginosis and keep treating for months, and that could be cervical cancer. So the aim of this presentation is to help us recognize gynecological cancers early, have a high index of suspicion when you see patients with some of these symptoms so that we can recognize early and then refer early, because a lot of the time prognosis depends on the stage. So the earlier we refer, the better it is for the patient. So what do we need before referral? First of all, like we mentioned, we would want general gynecologists or primary care providers to recognize the symptoms. So we need to identify the symptom pattern and examine the patient to try and figure out which kind of malignancy the patient may be presenting with. We need to take a focused history examination, and then if the patient is unstable, we quickly stabilize before we refer. We choose useful investigations to try and rule in or rule out the diagnosis, the differential diagnosis we have in mind. And then we make sure that we refer and refer appropriately. So there are 5 cancer sites that produce recognizable referral symptoms. And then we usually use a dominant symptom to narrow it in and then try and investigate towards that organ of source. So if usually postcoital bleeding, abnormal vaginal discharge, or a visible cervical lesion will indicate a cervical cancer. And in these patients, it's important that a speculum examination is performed and a possible biopsy done as well. And this is very dear to my heart because we have a lot of patients who go see their doctors with an abnormal vaginal discharge, persistent PV bleeding, and they've never had a speculum exam. They'll go in and out of hospital for 2-3 years and eventually present with advanced cervical cancer and will probably be eligible only for palliative care. If a patient presents with postmenopausal bleeding, your first differential should be an endometrial cancer. It is not fibroids. I've seen referrals with patients 60 years, 70 years, postmenopausal for 20 years, and then the diagnosis is uterine fibroids. A patient with postmenopausal bleeding, we always need to rule out endometrial cancer or at the very least endometrial hyperplasia. So these patients will need an endometrial biopsy done. If a patient presents with persistent bleeding, early satiety, ascites, or a pelvic abdominal mass, we should have a high index of suspicion for an ovarian or a tubal cancer. So these patients will require a CA-125, and then we try and do the risk of score her using the risk of malignancy index to ascertain her risk of ovarian cancer and then refer appropriately. And in patients with persistent vulval itch or vaginal itch, and also a lump or persistent discharge should have their vulva examined. Sometimes we perform the speculum exam without examining the vulva. The vulva could have a malignancy or an intraepithelial neoplasia or a precancer, so it's important that we examine the vulva as well. And then there are some symptom clusters that should also trigger a malignancy check. So a patient, like we mentioned, with postmenopausal bleeding, postcoital bleeding, or persistent or unusual heavy vaginal bleeding, you should think cervical cancer or endometrial cancer. If a patient presents with pressure symptoms or abdominal distension, we think ovarian cancer. If the patient presents with an abnormal discharge of pain, pelvic pain, dyspareunia, these may suggest cervical cancer. And if there's a visible vulval change, this could be a vulval cancer or vulvar precancer. So first contact with a patient like this, first thing we do, assess if she's stable or not. So a patient could be bleeding very heavily from cervical cancer. She could have a thromboembolic event, a DVT or a pulmonary embolism. or she could be in severe pain, or she could have obstructive features, urinary or bowel obstruction. We'll need to assess for these and then stabilize and refer urgently. These are not patients that you keep. And then if the patient is stable, you try and localize the site of the primary cancer, and then you refer appropriately. We'll talk a little about cervical cancer. We've already mentioned they will likely present with bleeding, an offensive vaginal discharge, or pelvic pain when the cancer is advanced. So there's this group of women that we should have a high index of suspicion for. So patients who are immunocompromised, especially patients who are HIV positive, they have a 6-fold increased risk of cervical cancer. So even if the patient is young or the woman is younger than the usual age range, but she is immunocompromised or has HIV, we should have a high index of suspicion for these patients. And another slide that is very dear to my heart. If the cervix looks abnormal, it looks funny, please do not perform a pap smear. So we have patients who present with a lump or a lesion or a mass on the cervix, an ulcer on the cervix, and we still go ahead and then do a pap smear for them. A pap smear is a screening test. It means that we perform these on patients who are asymptomatic or patients who have no signs or symptoms. So anyone who walks into your consulting room can have a pap smear. If she presents with any symptoms or signs, or if you pass a speculum and there's a lesion, then what she needs is a diagnostic biopsy, not a pap smear. So we inspect the cervix, and if there's any lesion, it could be a fungating lesion or an ulcerative lesion. We biopsy those. You do not perform a pap smear or an HPV test on these patients. And then the abnormal pap smear results, what we do with them. I've had several patients referred with a diagnosis of low-grade squamous intraepithelial lesion or an ASCOS pap smear, and then they've been told by their primary caregiver that they need a hysterectomy. Very rarely do abnormal cervical screens need a hysterectomy, or very rarely do abnormal pap smears require a hysterectomy. A lot of the time, the patients are also anxious because they really do not know what to make of these abnormal pap smears. So we need to understand what they mean. We need to triage appropriately because some of them, like the low-grade lesions, we only need to repeat the pap smear in about a year. So we reassure them and let them go and then make sure we have their contacts, call them back to have the repeat in 6 months to a year. But if they are high-grade lesions, then these patients will need to be triaged with a reflex test like a colposcopy, where we examine the cervix more carefully and either perform a diagnostic biopsy or treat in the same go. That's the screen and treat approach. So a high-grade lesion, you refer for colposcopy. We suspect is a cervical intraepithelial neoplasia 2 or 3. Those are precancers. These patients need to be treated, not with a hysterectomy, but with either excision or ablation, depending on the characteristics of the lesion. And we've mentioned already, avoid TH as total abdominal hysterectomy as much as possible. Occasionally, a precancer may harbor a focus of invasion or some cancer in it. And depending on the features of that cancer, she may need full surgical staging. So in that case, again, a hysterectomy may not be adequate. She may need lymph node dissection as well. So as much as possible, please let's try not to perform hysterectomies for patients with abnormal pap smears. And we all know that in Ghana, we do not have a standardized or national screening strategy or screening program. So every woman who comes into your office, that is an opportunity for us to screen. We do opportunistic screening. So it's important that as part of our history, we find out when the last time the woman has had a cervical screen done. And if it's been more than 3 to 5 years, depending on which one, then we should screen her. And we mentioned before that we screen asymptomatic women. We should start at the right age. The current WHO recommendation is that for the general population, we start screening at age 30 years. But for women living with HIV, we start at 25 years. The interval for screening for the general population is every 5 to 10 years if the test was negative or normal. If in the HIV, in women living with HIV, we repeat the test every 3 to 5 years. And WHO is recommending that we move towards a high performance test, which is the HPV DNA testing. So as much as possible, we should do that, or even do the co-testing, that's the PAP with the HPV. And we should remember that screening is part of a pathway, and we need to close the loop. So you screen, you need to report, make sure the patient gets the results, know what the results say, and know what the appropriate action will be. So is she supposed to repeat the test in 5 to 10 years, in 3 to 5 years? Does she need to be referred for a colposcopy? Does she need treatment? So we need to inform the patient of what to do after the pap smear. Last year, in the last quarter, Ghana introduced the National HPV Vaccination Program. And currently, last year, we vaccinated over 1.8 million girls between the ages of 9 to 14 years. So patients who walk into your consulting room, I think Dr. Nagai is going to talk about that. That's why I said patients and not girls. But patients who walk into your consulting room between the ages of 9 and 14 years, you find out if they've been vaccinated for vaccination. For boys, it is not free yet for them, so you can refer them to centers that can offer vaccination at a price. And there are a lot of myths and misconceptions surrounding HPV vaccination that we need to address. You may suggest it or recommend it to a patient or a patient's parents, and they may tell you that it may cause infertility, etc. We need to have our information right, and we need to disabuse their minds of all of this wrong information. And they also need to know that it works best, the HPV vaccine works best when the patient, girl or boy, has not been exposed to the HPV or the human papilloma virus. So it is important that they get vaccinated before they start having sex. We'll talk a little about endometrial cancer. We've said before that every woman presenting with postmenopausal bleeding should be investigated for endometrial cancer or endometrial hyperplasia with an endometrial biopsy. We would usually do a transvaginal ultrasound prior to measure the endometrial thickness in postmenopausal women. And a thickness more than 4 millimeters should trigger a differential of endometrial hyperplasia or cancer. But there are women younger than 45 years who we shouldn't assume have just uterine fibroids and do a simple hysterectomy for. So there are some women who have increased risk factors for endometrial cancer. These are women with chronic anovulation, those with PMOS. Those who have been using tamoxifen for treatment of breast cancer, those with Lynch syndrome, women who have an increased BMI. These women are at increased risk of endometrial cancer. So even if they are less than 45 years of age and they present with abnormal uterine bleeding or heavy menstrual bleeding, they should have an endometrial biopsy done. And if you scan a woman, a postmenopausal woman, the endometrium looks thin and she still continues to bleed, please do not stop there. She needs an endometrial biopsy. If you biopsy and the report says insufficient specimen, do not stop there. She need a hysteroscopy and targeted biopsies because she could still have endometrial cancer. So endometrial hyperplasia, we'll talk a little about this. We have two types now. It's now being classified into just two broad groups. Benign hyperplasia, that's endometrial hyperplasia without atypia, and then atypical endometrial hyperplasia, or what is called endometrial intraepithelial neoplasia. So the last one is a precancer. Without atypia is not a precancer, so you don't need to perform a hysterectomy for women with endometrial hyperplasia without atypia. They respond very well to long-term progesterones, and the risk of endometrial cancer in these women is very low. So we'll usually sample, and once you have that diagnosis, we may insert a Mirena and then follow them up for regression of the lesion with repeat biopsies. But women who have the precancer, that's endometrial hyperplasia with atypia, these women have a high risk of progression to endometrial cancer, and actually over 33% of them have concurrent endometrial cancer at the time the endometrial hyperplasia with atypia diagnosis is made. So these women do need a hysterectomy. In very few cases, these women may not have completed their families. So we would have to assess and exclude a cancer, and then may offer the Mirena, the levonorgestrel intrauterine system, and then we follow up with very close just for this follow-up. Again, total abdominal hysterectomy and bilateral salpingo oophorectomy is not complete endometrial cancer staging. For most cases of endometrial cancer, complete staging would involve lymph node sampling, lymph node dissection, either sentinel lymph node dissection or complete pelvic lymph node plus paraortic lymph node dissection. So we do have a lot of patients come to us who have been offered just a THBSO in the periphery. So these patients have been understaged. So what this means is that we still do not know what the stage is. This means that we either have to reoperate, restage the patient to try and sample the lymph nodes to restage to be able to decide the definitive or the adjuvant therapy. If we cannot do that, then it means that we usually overtreat these patients. So then these patients will have to be offered radiotherapy plus or minus chemotherapy, and some of them may not have needed it. So then we subject them to the complications of radiotherapy and chemotherapy because we did not fully stage. So as much as possible, once the diagnosis of endometrial cancer has been made, please let's refer to gynae-oncologists for full surgical staging. And before operating, we need to answer 4 oncology questions. The first is, what is the diagnosis? We need to obtain the appropriate tissue diagnosis where indicated, and then request expert pathology review for unusual disease so that you can offer the appropriate surgery. Because sometimes you can get a biopsy result and it's still inconclusive. We need to go back to the pathologist. They need to do immunohistochemical stagings. We need to meet with the oncologist, have a multidisciplinary meeting to discuss the way forward. And then we need to know how extensive the disease is. So before every surgery for a presumed cancer, we need to do what we call a metastatic workup. We image the rest of the body to find out how far the cancer has spread before we offer surgery. So for example, you may do a CT scan of the abdomen and pelvis and this disease looks like it's confined to the uterus. An endometrial cancer may look like it's confined to the uterus, but we forgot to do a chest x-ray or a CT scan of the chest, and she may have pulmonary mets there. So she's already at stage 4, and then the THBSO you offer is inadequate. And then we need to know what operation is required. So depending on the tissue diagnosis and depending on what your metastatic workup tells you, then you decide on the appropriate operation to offer. And also know when to refer, who should be performing the surgery. Because if we cannot perform lymph node dissection, then we shouldn't be operating on most cases of endometrial and cervical cancer. We talk about ovarian cancer. Persistent ovarian symptom clusters warrant assessment. A lot of us walk around with abdominal pain, bloating, our tummies are getting bigger, but we think we are gaining weight. And most of the time, this is right. But if the symptoms are persistent and if the bloating and distension is not occurring with meals, then we need to investigate more closely. If a patient presents with early satiety or persistent pelvic pain, or there are urinary or bowel symptom changes, so new onset diarrhea or constipation or frequency or urgency, we should think ovarian cancer and try to rule that out. So this is a score, what we call the risk of malignancy index. It's a way of triaging patients to try and ascertain whether they are at high risk of ovarian malignancy or not. And this tells you whether to perform the surgery in your facility or to refer to a gynae-oncologist. So with the risk of malignancy index, this is the 1. We multiply some ultrasound features by the patient's menopausal status and then the CA1 to 5 level. So for the ultrasound features, we score 1 for each for multilocular cysts, for solid areas, for METs, for ascites, and for bilateral lesions. So if it's 0, if none of these was present, the score is 0. If there's 1 present, it's 1. If there's 2 or more, you score as 3. If the patient is premenopausal, you score 1. If the patient is postmenopausal, you score 3. And then the CA1 to 5, you use the absolute value. So if your score, you get a score greater than 250, it's likely that it's an ovarian cancer and you need to refer to a gynecologist. So this is an example of a patient who had an ultrasound score of 3. She was menopausal, so that was another 3. And the CA1 to 5 level was 80. So it's 3 times 3 times 80, and then you get 720. So this is high. She likely has an ovarian cancer, so she should be referred to a gynecologist. So now on high-grade serous ovarian cancers, we now know that most of these are arising from the fallopian tube. They're actually primary fallopian tube cancers, and they originate in the fimbrial end of the tube. There's an actual precursor called STIC, serous tubal intraepithelial carcinoma. And because of this, what we are advocating worldwide is that in our benign surgeries, we take out the tubes, because a lot of cases of ovarian cancer will originate in the tubes, not de novo ovarian cancer. So if a patient comes and is requesting a BTL, this is a good opportunity to actually, if she's requesting a bilateral tubal ligation, it's a good opportunity to perform prophylactic bilateral salpingectomies, get the tubes out to reduce her risk of ovarian cancer. So we should, and then also for our hysterectomies as well, especially now that we are leaving in the ovaries for premenopausal women and women before the age of 50. Even though we leave the ovaries in, we should try and take out the tubes as well. So we've talked about STIC. And then vulval and vaginal cancers. These are not too common in our part of the world. But if a patient presents with persistent itch, we need to examine the vulva. If there's a lump or an ulcer, let's biopsy it. So we do an incision biopsy, meaning that we take a little of the lesion and leave some of it or as much of it as possible. Because if we cut out all of the lesion and it comes back as cancer, you have to refer to the gynecologist, and then he or she will need to re-operate. Sometimes it would heal and it will not leave a scar. So you do not even know where the primary lesion was to be able to operate and then get the margins that are required. So as much as possible, don't take all of the lesion out. Do an incision biopsy. We'll talk a little about gestational trophoblastic disease and neoplasia. So after a woman is pregnant, has delivered, or after an ectopic pregnancy, or even a miscarriage, if she still has persistent or heavy bleeding, let's have a high index of suspicion for gestational trophoblastic disease or neoplasia. So then we'll need to track her beta HCG levels. Or in a pregnant woman who books first trimester, second trimester, especially first trimester, and she has disproportionate hyperemesis, she has a very large uterus, larger than date, the beta HCG levels are very high, or she has early onset preeclampsia, or respiratory distress, neurological symptoms, elevated thyroid hormones, let's suspect gestational trophoblastic disease. So the risk history changes the threshold, not the symptom. Like we mentioned before, some of the symptoms are very benign. But if you have, for example, a woman in her 60s presenting with bleeding per vaginum, that's a high index of suspicion. HIV/AIDS, women living with HIV/AIDS, we should have a high index of suspicion for them as well. And then we should go into the family history. A woman who has a first or second degree relative who had breast cancer, ovarian cancer at a young age, she's also at high risk of a gynae malignancy. So we mentioned before, we should assess whether she's stable or not. We should assess whether there's abdominal disease. Is there visible lower genital tract disease? Please, let us pass the speculum. Let us pass speculum as much as possible. For vaginal discharge, for bleeding per vaginum, let's pass speculum to look at the cervix and the vaginal walls. So we should investigate to support the referral, not to earn permission to refer. Sometimes we are a little worried about referring. We think that when the patients arrive at our end, we are going to question every decision and why didn't you do this? Why didn't you do that before referring? We prefer that the patients come in as soon as possible so that we don't request investigations that they don't need, because some of these can be very expensive. So for the bleeding per vaginum, women we suspect with endometrial cancer, we should do the endometrial biopsy if we can. If not, just refer. If they have the pelvic mass, a CA125 will be useful. If you can't do it, refer. And if there are visible lesions on the vulva, please refer. Or if you can do an incision biopsy, please let's do that. So these are a few case scenarios. We have a 62-year-old female. She's had one episode of painless spotting. It's just spotting. She has no history of hormone replacement therapy. And then when we examined, we didn't find anything. The uterus was small, it wasn't enlarged. We passed the speculum, no lesions. We scanned, the endometrial thickness was about 4 to 5 millimeters. We don't reassure such a patient. We don't assume that it's atrophic vaginitis. You need to rule out endometrial cancer or hyperplasia. So she will need an endometrial biopsy. And we have a 54-year-old. She's had 6 weeks history of bloating, early satiety, and urinary frequency, and her clothes are getting tighter. On examination, there's significant ascites, so this patient should be urgently referred. You can do a CA125 for her to come along with. If she's not able to do it, just refer urgently. Then a 68-year-old, she has a 4-month history of focal itch on the vulva and soreness. And then we gave some topical steroids, or we gave some topical antifungals, and then there was temporary improvement, but then it recurred. So eventually we examined and saw a 1.5 cm indurated ulcer, which bled with contact. This patient should be biopsied urgently or should be referred urgently for biopsy and then follow-up. And then this one, which is quite dear to my heart, she's presents at 56 years. She's had 2-year history of, she's been menopausal for 2 years, and she had hysterectomy. The diagnosis comes back as endometrial cancer with deep myometrial invasion. We haven't done lymph node dissection, so we haven't been able to fully stage her. So such a patient has to be referred to us. We need to decide whether we are going to re-operate to restage her, or we are going to offer definitive adjuvant treatment with chemotherapy plus or minus radiotherapy, and this is likely going to be over-treatment for this patient. So 3 behaviors shorten the pathway to diagnosis. The first is that we examine the sites that we suspect. If it's a cervix, vagina, vulva, let's examine. And then the symptoms. If they are persistent or they are recurrent, or there's high risk, for example, in HIV, women living with HIV, then there's a higher index of suspicion. So we need to investigate quickly and then refer. And we should refer the right agency. We should let the patients know how urgent their condition may be, and then impress upon them to come to the referral sites. Sometimes they don't like coming to some of our referral sites, but please let them know it's important that they come. Thank you very much. So that brings me to the end of my presentation. But I just had a few questions for you before you ask me any questions. So in your own facilities, where do you think the delays occur in your pathway? And then which red flags do you think we usually would miss or we normalize? And the third one is, what is one thing that you change going back this week? Thank you.
Thank you very much, Dr. Ama. Oh, have you recorded the questions? Yes. Very good. Yes. Yeah. So you have time to answer those questions. The chairman has assured me that there will be enough time for questions. He wants us to finish with the second presentation so that we combine our questions. So you can put your questions down and then also add that of Dr. Ama. When the time comes, You answer your questions, and then she will answer the questions that you pose to her. Now, our second presentation is on the topic prevention of cancers, role of vaccines, education, and innovative research. And our facilitator is a professor of public health. He is also an international development practitioner with over 20 years of experience in the area of global public health. He is a man who wears many hats in both the academic and the medical fields. For instance, he is an immunization technical expert and provides technical advice or assistance for immunization programs as JSI Ghana. He lectures at the Ghana College of Physicians and Surgeons in Accra and at the School of Medical Sciences, KNUST Kumasi. He's a consultant at Ghana Canada Medical Center in Accra. He's the right person to deal with this topic. With a round of applause, let's welcome Professor Nagai.
Dr. Slipsai wants the GTech people to chase me. So it's nice to be in this city again. I call it a city. When I arrived at the entrance, there was a young, no, she's now quite old, and asking me, am I coming to train people in the area of HIV again? This is because in 2008 and 2009, we used to train a lot of healthcare workers here. I'm coming to speak about prevention of cancers, and I'm coming to talk more about the extreme left side of the spectrum before we give the problems to Dr. Ambagani and the team. And a lot of work has been going on in this area for some time now. I want to make sure that we can see the slides well, but I hope they appear well. Africa's cancer challenge is increasingly being seen as a preventive challenge. A lot of the problems that we see within the wide spectrum in the area of the cancers is becoming more of, Ghani might have gone through some of the statistics, which I don't want to repeat. But when you look at the extreme left of the slide, I don't know why they are occurring this way, but the opportunity, approximately 38% of cancers can currently be prevented with existing evidence-based strategies. This we know. This slide talks about some of the cancers that can be prevented. And we know that infections create pathways that leads to the development of cancer. And I'm very careful in describing this. They create the pathways that leads to cancers. The first one is the human papilloma virus, which we know the infection by certain serotypes, and I'll describe them, leads to cervical, anal, vaginal, penis, and oropharyngeal cancers. I became very much interested in this area because I've lost an auntie who died because she had cervical cancer, and also a family, a friend who was about 78 and died because of oropharyngeal cancers. Maybe what we'll be discussing here in terms of prevention, if that had happened, they probably would not have developed that. So HPV is one of the key ones we have to take home. We also know about hepatitis B virus, and then hep C virus that leads to hepatocellular cancers. Let me quickly add, for hep B, we know there is a vaccine. For hep C, we don't have a vaccine, but we know as clinicians how and what we need to do in order not to contract hep B, hep C infection. And I'll talk about this. We also know much now because we are clinicians who have been dealing a lot with the treatment of H. pylori, which we know has the pathway leading to the development of gastric adenocarcinomas. Epstein-Barr virus, we know about that infection and that it leads to Burkitt lymphoma and other nasopharyngeal cancers. HIV and human herpes virus 8 cause cancer, Kaposi sarcoma. And in my practice in Atua Government Hospital and the St. Martin's Zibori Hospital at Agomenya in 2006, 2007, when we did not have a lot of antiretroviral therapy, we used to see a lot of Kaposi sarcoma because of HIV infection and human herpes virus 8 infection. We also know that when immunity goes low as a result of HIV 1 and 2 infection, then the predisposition to having HPV infection that leads to cervical cancer is high. So infections are important when it comes to cancers. They are often preventable, and they create the pathways for the cancers we just described. For HPV, I cannot leave this podium without talking about these serotypes and the vaccines we have to ensure that we can prevent these infections from taking root and leading to the cancers that are associated with them. So when you look, we have specific serotypes that lead to these cancers. The one in the wine color, the 4 serotypes there, and then the one in the green, which is the other serotypes. All of them, about 9 of them, are serotypes that lead to cancers associated with HPV infection. Cervical cancers, we mentioned penile, we also mentioned oropharyngeal cancers. As we speak, and as we are all aware, we have a quadrivalent vaccine, which is Gardasil, being provided by the EPI for immunization. And Dr. Gani mentioned the age group, as we know, 9 to 14. That is what the public sector is providing, and for girls. And that is what we can do. That is the primary target group. But as has been mentioned, we as provided in the private sector, and I always call our attention to this, that we don't end where the public sector ends because of resources and because of the target population involved. We need to know that boys will need to be vaccinated as well because of oropharyngeal cancers and the other cancers, the non-cervical cancer types of cancers that are associated with HPV infection. Also, age 15 to 24, there is benefit in HPV when we have HPV vaccine being given to those who are aged 15 to 24, and even from 24 to 45. There's always an argument, and I get it everywhere, so I'll answer it before I sit down, because oncologists are here as well. And this is about the type 35. Every time I get that question, yes, we don't have a vaccine against subtype 35. That would be read in the Ghanaian literature and in sub-Saharan Africa that also leads to cervical cancer, about 10% of that. And we all know why. Vaccines development through the stages happen in areas where we don't have a lot of type 35, so the focus has not been done. But there's a lot of advocacy for that. Hep B vaccine, we know that this is also key in terms of preventing Hep B-associated hepatocellular carcinomas. So cervical cancer in particular can be interrupted at 3 decisive points: vaccination, screening, and treatment of precancer promptly. At this point in time, and as we continue to promote through our society, that we should be able to support government to the point that a generation from now, we should be eliminating cervical cancer so that we reduce the burden on our OBGYs and the surgeons. It is possible when you look at this pathway and where we can interrupt it. Now, let me look at the areas of education. Education is key, like this meeting that we are having here, to enable us understand what is preventable. It is important that as practitioners, we are able to support education around the preventable cancers by explaining the risks, correcting some of the myths, make sure that clients can take some action based on the information that we give them. And then also reaching out to families, families that come to our health facilities. We've had programs that have targeted schools, workplaces, faith groups, and different forms of education. Currently, we know that 1 2-minute video clip can reach about 500 people within 2 minutes. And so when you look at what is happening now, we are moving faster in the area of providing information. We are no more using the traditional INC materials where we are printing things around. You can see that when you go to places and things are printed, people don't even pick them. Everybody is looking at some clip, some video, etc. So that is the way that more and more education and social and behavior change communication information is going about this. And we as clinicians have to get involved and make sure that we can provide the necessary information, educate clients that come to us, and help us to prevent these cancers, those that are preventable. So a very important, simple schema that we use, especially in the public health sector, is about these ask, advise, act, and track. Every consultation, if we want to eliminate cervical cancer, in our lifetime, all of us sitting here, every consultation can become a cancer prevention checkpoint. We ask questions. What is the vaccination status? If it is for HPV, if it's for hepatitis B, just that simple question can prompt a family to be able to get the jab. Matters about tobacco. Alcohol is now established clearly, without doubt, that is a carcinogen. We used to say, okay, take a little and it is fine, etc. But we need to read and get the information across to everybody that is now established that it is a carcinogen. For example, what's the family history? Are there symptoms or exposures? And then advice. Give clear, personal, tailored recommendation. The trust that we have as clinicians of our clients, of the patients that visit our hospitals is huge. And then we act, make sure that vaccines can be available. And I just want to use this opportunity to say that this month, there will be a major launch of HPV vaccine rollout within the private sector is to make sure that it becomes accessible and affordable and everything that we know that can make people to easily get the jabs into arms when it comes to HPV vaccine. And then also tracking, making sure that we are serious about whatever screenings are there. We are making sure that we get pre-cancers that are identified, treated. There is an area that is evolving very fast. And last year, the level where genetic testing will be done on kids. So you are able to know and predict what kind of cancers based on family histories and everything worked out can occur within the life of that individual. So genetic testing identifies inherited risk. We say that it is evolving fast, but it will never replace screening, as it were. So, for example, we all know about the BRCA 1 and 2 tests, for example. So, germline testing, as we call it, looks for inherited pathogenic variants present in all cells. As I said, some countries have started where this is being part of the regular screening that will be rolled out. Processes that identify tumor testing, for example. And the main purpose here, as you can see, tumor testing, the main purpose is for diagnosis and then prognosis and treatment selection. We all know when you come to even prostate, when you come to other forms of, the testing can lead to specific directed treatment options that are available. In the private sector, we should be thinking around genetic testing, systems that look at better tumor testing approaches. Population screening happens a lot for the public health side of things. We know in some countries we have mammography that is being rolled out. It's not a very common procedure for the entire population, but we know even at individual levels that we do that. Cervical screening has been one thing that we've been pushing along a lot in our chronic disease management programs. And the private sector have to take this on board and help to support government in order to reach more people within the country. So for a genetic pathway in terms of testing, before we do the usual laboratory areas, the laboratory tests. The first item that I would like to call our attention to is what we call the risk assessment. Some countries have trained clinicians and there are units within their facilities. For example, where I did some work in Belgium, where if you want to go through genetic testing for a particular problem, you go through the entire steps. And it is helpful because those who can afford are able to go through that process. And it involves risk assessment, it involves pre-test counseling, it involves getting access to the appropriate test. Sometimes a targeted gene or multi-gene panel. Then interpretation is very important. You have to have people who can interpret, the tests that have been done. And then what kind of action you want to take. Services to ensure that whatever action you want to take, you are able to follow through that path is available. These slides will be available on our platform, our official platform for us to go through. But some of the high risk, syndromes that can trigger an early and tailored prevention, we can be able to see them through genetic testing. If the decision is that I may need to remove some part of my body, if the decision is that I may need to do something early as a result of the report of genetic testing, all that can be possible in preventing future development of cancers. Now, there are blood-based multi-cancer promising, although not widely available yet. But there are assays that are being developed currently, as some of us were aware in our earlier webinars, to look at testing for cancers, blood testing for cancer to detect, early. You'll be able to detect early before even symptoms develop. And that is the direction that things are going very quickly as we speak. I was looking at what can we do in our part of our world. What are the areas for African research that could enable us solve some of the issues that we have regarding delivery, the biology of cancers, and then some of the things that we see relating to equity. There are a lot of work that we need to do in the area of implementation. How can HPV vaccination, HPV, Hep B vaccination, how can we make sure that these are reaching our people? What about the area of genomics? Are we going to develop the platform, the services that will enable us detect cancers early before symptoms develop? Can we make sure that we can have affordable diagnosis for our people? So we have all these areas that we need to be looking at and be thinking about, even in the private sector. Because there are some of the services, as we know, that are currently in the private sector. Some of our members have services available in their facilities currently that are not readily available in the public sector. There are many things that we need to do when it comes to the people we serve, the data we collect, and the kind of trust that we can generate when we are able to put everything else together, especially when it comes to the private sector. I group them into, our communities, the laboratories, research and policy, and especially the primary care services that we provide that benefits a lot of people. These are 5 actions that for us as members of the private society, we can begin today in supporting the government and supporting the country to respond. In our practices, our clients trust us. Let's ask about their status when it comes to these 2 vaccine preventable diseases that can happen. Cancers that can be caused because you have HPV vaccine, HPV infection or HBV infection. I mean, the cervical cancers and then the hepatocellular carcinomas. Let's offer clear and confident vaccine and screening recommendations. If they are not vaccinated, we support the decision-making for them to take the vaccine. We can use structured family history tools and refer high-risk patients, as it were. So there are a couple of things that I think that we can take home today to make sure that we can be supporting the country to respond better to the situations of cancer. The last but not the least, partnership with locally led implementation research and cancer registries. I was talking to our colleagues in the chronic disease area, and the issue of our cancer registries and data input and data submission is actually a problem. And they think that the private sector is the worst culprit when it comes to submission of data and the requirements that they need to build registries. I feel that this is something that we can contribute to. And if there is a research that is taking place, we should be able to participate as a private provider or a site in supporting whichever research is ongoing in the area of cancer prevention and management. Prevention is better than cure. And the best cancer is the one that never develops. Vaccines are important, and we've spoken about them. Education of our clients are important. Genomics testing is coming up.
The questions will come later. Right now, you invite Stanbic Bank to make a presentation. They've been our partners for a long time. Today, they have a message for us. So Stanbic, you are welcome to the AGM.
Good morning, everyone. So I thought you were excited to see us. We are going to class some more. Thank you. That was refreshing to hear. We are from Stanbic Bank, as originally and introduced. Thank you so much for the opportunity to exercise our expertise as the best dependable financial partner for these programs. We always partner the Society of Private Medical and Dental Practitioners, and we are so grateful for giving us such an opportunity. A lot of banks in the industry, however, you deem it fit to invite us to partner with you. We are so grateful. Today, we have placed so much premium on the program. Our team came in yesterday. We also drove in this morning, and we have more people coming in. We are from affluent clients. I am Ama Chineboa-Kodua. I am the head of executive banking. I have my boss here, Omar Kahi, who is the head of personal markets. He's here to join us. He was here yesterday. We have our business development manager also on the ground. We have the branch manager of Ho Branch also here. And then we have a number of our staff on ground. The good news is that we are here to present to you a gift at your doorstep. We have a bouquet of financial solutions that we want to talk to you about. We want to be the first port of call for your financial queries. We don't want you to be wondering about how I can get this done or how I can have this at this point in your financial journey. So we are here to bring banking closer to you. In executive banking and private banking, we solution for clients such as yourself. We have our business development manager, and everybody. Yours has your colleagues telling us what will be exciting for you. We have put everything together and we are going to present this to you as your special gift for your annual general meeting. So stay tuned. We have solutions spanning from what you can do as being transactional, investment solutions, insurance solutions, lending solutions, and we do financial wellness advisory solutions too for you. So it is a whole myriad of solutions. You won't be left out. At least you have a part to play in what we have available for you today. So we'll be outside during your break. Kindly speak to us. You may need it in the future, but please talk to us today and we will be very positioned to support you to make your financial journey an exceptional one. If you are happy to hear that, you can just click for us or give us a clap. Wow. Thank you so much. So we'll engage you some more outside or even within the walls. Thank you.
Thank you, Stanbic Bank, our partners. Now,
My name is Abdul Razak Dokurugu from Upper East. Let me take the opportunity to thank the two presenters for the very beautiful insight. I had a question for Dr. Ghani, but at the tail end of her presentation, she also gave us some questions to answer. So I want to turn my question into a response to her first issue about delays in the referral pathway. Most often than not, this poses a serious challenge for those in rural practice. There's a certain perception, whether real or imaginary, that investigations that come supporting referrals to bigger facilities are often considered as substandard. And so you are in a rural area, you have a case, you think these investigations are the relevant packages you need. And they get to the receiving facility, the receiving end, and those investigations, because they are not coming from very popular standardized like maybe Lancet or any other place, they are more or less not considered. And the clients are asked, the patients are asked to do the same test at recommended laboratories. And that contributes to the delay. So when you have a case, you are not sure whether you should send to a standard laboratory, ISO standard facility, laboratory. And so we expect that results of investigations emanating from those facilities should be considered as standard. But this is a real challenge, and I want us to look at it together. I mean, what is the most recommended way for those in rural practice to cut short these delays in the referral pathway for the specific cancers, in this case, cervical cancer? I had taken that as a question, but now that it came as a concern, maybe let's all deal with it. Rural practice, referrals, what are the major pushing factors that we can facilitate for clients to have easy access to specialized care? Then my second issue, just quickly, is to Professor Nagai. You mentioned the pathways, the break in the chain of cancers. And you mentioned vaccination, screening, and treatment of early treatment of pre-cancer investigations. I want to ask, as somebody so influential, you're an academician, you work with policymakers, when are we expecting a national policy on cancer screening? When are we expecting standardized guidelines? As we stand now, if you talk of HIV, you can point your finger to what we should do. If you point to malaria, you can identify clearly what we should do. If you point to TB, it's all clear. Now, the cancers are fast emerging.
Please, when you take the mic, for the benefit of those who are listening to us online, please introduce yourself. Thank you very much. Any additional question?
Good morning, and thank you very much. My name is Joseph Somwa Akuamwa Otumfo from Central Region, Kaswa to be precise. Thank you very much for your presentations, especially Dr. Amma Ghani. Just like Dr. Razak, her concerns is when you have a case sitting in front of you and you know you don't have the resources to manage that case, and you know that this person must go to another facility where they have the specialists, they have the consultants, and then they have the equipment to manage that case. Where do you refer them to? How many gynae oncologists do we have in Central Region? How many do we have in Upper East? Upper East region? I don't know. Where? Who? How? These are my questions as an epidemiologist. Thank you.
Thank you, Dr. Somwa. We take the last question, the last group of questions, and then we start again.
My name is Dr. Yi N. Yemo, Greater Accra, Lakeside Clinic. You know, every October, almost all Ghanaians know that we have breast cancer month. Is there a time, or would there be a time, when we shall devote a whole month to cervical cancer? Thank you.
Thank you, Dr. Yemu. Now our presenters will answer your questions.
Thank you very much. I think my questions are very difficult. I'll do my best. Maybe we can brainstorm and come up with ideas together. So the question on the laboratory investigations. Yes, we prefer labs from standardized. We prefer investigations from standardized labs. And sometimes when we are not too sure where the lab is coming from, we may repeat, especially if the labs were done weeks before the patient was referred. If a patient is going to go for surgery, we'll need the basic pre-op lab, so we'll likely repeat those ones. But ones like the CA125s, etc., usually we would not repeat. If you think, or the patient thinks that we may have to repeat the labs when they get to us. Then let's do the most basic of labs, and then when they come, we would repeat them, or we'll do them at our facilities or at the more standardized ones that we all know about. I don't know if this is acceptable. We do the most basic to get a diagnosis, and then the rest of it, especially the metastatic workup, we'll do when the patients get to us. Then on the guidelines, I know that's your question, but last year the Society of Obs and Gynae of Ghana launched or published cervical cancer screening guidelines for the entire country. So I'll probably share with the president, and he can put up on your platform. And then the question on the number of gynae oncologists, I think I opened myself up for this one. We are very few in the country. There's one in the Volta region. There is one in Kolebu, and there are 3 or 4 being in training in Kolebu. There's one in UGMC. There are 2, you can count them. There are 2 in Confanoche and about 8 in training in Confanoche. So hopefully in the next 2 years, fingers crossed, every region should have a gynae oncologist. So these are where the gynae oncologists are concentrated currently in the country. And then we do have a cervical cancer awareness month. This year we celebrated it's end of January into February. We celebrated it in most of the institutions in the country. Our color is teal green. I think there was a bit of hullabaloo made about it, but not as much as breast cancer. So I think we still have a lot of work to do in the area of cervical cancer. Thank you.
No, I think that Dr. Ghani had answered all the questions, which is great. The screening guidelines, and I think this is one of the best products SOGOG has produced. So let's give them a hand. It was good. We actually put it on the platform, but we will share it again. It's available, it's electronic. Then I will add to the awareness month. I think that we have awareness month for various, if you like, cancers. And I think, let me take the opportunity that when we have the awareness month, that for cervical, which is January, February, we should all get involved. It's so important, because then we'll be able to have various webinars, etc., done, and then more education can go out. Let me make a contribution to a question Dr. Somoa asked about who is where and when and all that. The society, as you know, is evolving or developing a referral directorate. We are hoping that by the end of this year, that will become live on the website. And that is going to be a major, although, well, if you are not in good standing, you will not be in it. But we expect that it's going to help a lot for the access to where, who, if it will become live. Give enough time for that. But a year by this time, when we have another AGM, we will make sure that that had gone live. And it will be a very important tool for that. So that's what I can add. Thank you.
Thank you. Now you go for a second round of questions. Are there any questions online? So please, if you have a question, raise your hand.
Thank you very much. Thanks very much for answering my question. Just curious, why are the young doctors running away from gynae oncology training? Do you have any particular My seniors are laughing at my question. Is there any reason? I'm asking this because I know one young man who appeared for your interview session before he was trained. He has been trained as a member of the Society of Obstetricians and Gynecologists. So my impression is that definitely he said he wanted to be a gynae oncologist. But these days when I talk to him, he's not talking about it again. Why are people afraid of your area? Why?
Amma will answer that. The next question, please.
Thank you so much. My name is Dr. Sebastian Yidana, working in the Northern region. This also to Dr. Amma. So thanks so much we are all talking about prevention. And when you go to the ovarian part, you spoke about how removing the femoral end of the tube helps. We do a lot of bilateral tubular ligations. But then when we are training younger doctors, everybody is training them to do Pomeroy, at best maybe Parkland. So why are we not concentrating on that method where we can just do a fimbrectomy for everybody, knowing that will mean that all those that would do BTL for would have prevented ovarian cancer for them? Maybe some form of advocacy for that. Thank you.
Thank you, Dr. Idana. And the last question for this group. Dr. Da, you are welcome. That's our Volta Regional Chaplain. Okay, if there's no questions anywhere yet, Amma will answer your questions.
Thank you very much for the difficult questions again. So the first, I would just hazard a guess. I would say that training is difficult, it's long, and it's psychologically draining because, in a setting, our patients present late. A lot of the times, all you're offering is palliative care. Eventually, they may pass. So psychologically, it takes a toll. And there are other subspecialties in obs and gynae that are more financially rewarding. Yes, my colleagues in reproductive endocrinology, IVF, they are really enjoying. So when you talk to the young ones, the young members, that's where they want to subspecialize in. So these are a few of the guesses I would hazard. And Dr. Sebastian, I think you are very right. I think it falls on SOGOG to promote prophylaxis salpingectomies or fimbrectomies as opposed to the Pomeroy's method when it comes to BTLs. Yes, you are right. It's an area that we would need to do a lot more work in. Thank you.
Dr. Ghani, thank you very much. We have a lot of time on our hands, so if you have any questions, you can bring them up. We'll be able to manage the time to the extent that we are within time. Any questions from our online platform? No question from our online platform. Mr. Chairman, we have to be getting ready to round up the session for this morning.
So let's give a last round of applause for our expert facilitators. Cancer is, to not use the word taboo sometimes in our society. So we thank our esteemed presenters for doing well to the topic. I'll pick two lessons. The first is on gynecological malignancies, and I'll just go by what was written there. Recognize early, refer early. Our prof also told us something about blood testing, which I think will be an easier way to detect cancers, and I hope he will work on that for us. And for us practitioners, the 5 actions he talked about, let's try and trust and use it for the benefit of our patient. Thank you all. Thank you.
Thank you very much. Lunch break starts at between 12 and 1:50 p.m. We are within time. Yes, I believe. So we are closing for the morning session. We will come back after lunch at 2 p.m. to continue with the second scientific session. Thank you very much.
Je suis perdue sans toi. Je me sens seule sans
Good afternoon and welcome to the afternoon session. We invite Unichem to give us a presentation. Unichem Pharmaceuticals.
Good afternoon, everyone. Okay, so my name is Dr. Lydia Aglobiche. I'm a pharmacist with Unichem Ghana Limited, and today I want to talk about one of my products, Zyphine M. Okay, so I'm going to start with a disease background. So allergic rhinitis is a chronic IgE-mediated inflammation condition which affects about 15 to 25% of the global population. And it normally occurs after exposure to certain allergens such as and then nasal congestion. So with allergic rhinitis, we have both the early phase and then the late phase, where the early phase normally occurs few minutes after exposure to the allergen. And it's normally caused by histamine release by the mast cells. When that happens, it also causes symptoms such as the sneezing, the rhinorrhea, itchy nose, watery eyes. Then we have the late phase, which normally occurs hours to days after exposure. And it's also caused by inflammatory mediators such as the leukotrienes. So with the symptoms of the late phase, we have the inflammation, we have tissue swelling, we have nasal congestion, we have bronchospasms, bronchoconstriction as well. It's not working. Yes, please. Okay. So with the management of allergic rhinitis, we have three main managements. The first is avoidance of the allergen. The second is patient education. And then we also have pharmacological treatment. So on the table, you see, we have a list of different pharmacological treatments. And my interest is more of the antihistamines and then the leukotriene receptor antagonist. So from the table, you can see that with the antihistamines, it tackles symptoms like the rhinorrhea, the sneezing, and then the nasopharyngeal itching. And for the leukotriene receptor antagonist, it tackles ocular symptoms, the rhinorrhea, and then the sneezing. On this table, we are having various types of antihistamines. So we have the first generation and then the second generation. And from the table, you can see, I'll talk about just a few. So my interest is desloratadine, fexofenadine, levocetirizine, and then rupatadine. So from the table, you can see that there are three sections: the onset of duration, the time to maximum plasma concentration, and then the drug-drug interactions. Desloratadine has about 2 hours of time to onset of for the medication to work, and then it also has about 1 to 3 hours time to steady state plasma concentration, and it's unlikely for drug-drug interactions to occur. For fexofenadine, it also has 2 hours onset of action with 2.6 hours time to maximum plasma concentration. Also, drug-drug interaction is unlikely to occur. Then we have levocetirizine, which has 1 hour onset of action with 0.8 hours. That's about 48 minutes. Time to maximum plasma concentration. Again, it's unlikely for drug-drug interaction to occur. And lastly, we have rupatadine, which also has 2 hours onset of action, 0.75 duration to maximum plasma concentration, and then there's usually some drug-drug interactions with rupatadine. So now let me talk a little bit about montelukast. Apart from it being a leukotriene receptor, it also presents with some benefits to asthmatic patients. You know, in asthmatic patients, about 80% have allergic rhinitis symptoms. And so they normally have this congestion and then the inflammation in their airways. But with montelukast as a medication, it's very useful to these patients, this group of patients, because it helps reduce the bronchospasms that they normally have, and then also attenuates the inflammatory response. So now I'm introducing Xifen-M, which is a combination of 5 milligram levocetirizine and 10 milligram montelukast. So from what I said earlier, I spoke about the early phase and then the late phase. So that's where Xifen comes in. The whole rationale behind Xifen-M is to tackle both the early phase and then the late phase of allergic rhinitis. So with blockade of histamine, with levocetirizine, and then the leukotriene antagonist receptor antagonist, we will have broader control of symptoms that your patients will present with. So levocetirizine, being a prodrug and an H1 antagonist, it also has a faster onset of action because the medication is already in its available form. It doesn't have to be metabolized before the body will use it. And thus, it also has very effective control over the early phase symptoms. We also have montelukast, as I've said. It helps with control of the late phase symptoms. Hence, it reduces the nasal congestion, the inflammation. It will also reduce the bronchospasms and then the inflammatory response. And it's very useful in patients who have coexisting asthma. Okay. Okay, so in this table, we are differentiating between the Xifen-M combination and single monotherapy antihistamines. So we can see levocetirizine montelukast, we can see levocetirizine on its own, we can see fexofenadine on its own, and then desloratadine. So the Xifen-M combination has a dual mechanism of action, being the H1 receptor antagonist and then the leukotriene receptor antagonist, whereas the others tackle only the H1 receptor. With congestion relief, Xifen-M combination has an excellent relief of symptoms of congestion as compared to the others, the single therapy. With asthma comorbidity use, the Xifen-M combination can be used, but with the single monotherapy, it wouldn't really do much. And for sedation risk, the Xifen-M combination also has a low sedation risk. So there are three main groups of patients that Xifen-M is very beneficial to. We have those with moderate to severe allergic rhinitis. We also have those with the asthma and then the allergic rhinitis overlap. And lastly, we have patients who have nasal congestion dominant symptoms in allergic rhinitis. So with these classes of people, when they take Xifen-M, they get better relief and then they are able to breathe better. So Xifen-M comes as a tablet. In the box, it is a tablet of 10, being 60 cedis, at the cost of 60 cedis. And it's a once daily dose. It can be taken with or without food. However, it should be used with caution in patients who have urinary retention, who have renal impairments. With neuropsychiatric patients, you also have to use with caution. And patients who have idiosyncratic sedation, it also has to be used with caution, preferably after work, because they might feel very drowsy and then they may not be able to function. It's also contraindicated in pregnancy, in all stages of pregnancy. So your pregnant women cannot take them. With breastfeeding mothers, the benefits to risk ratio has to be assessed before you give Xifen-M. And it's also contraindicated in patients below 15 years. Hence, it's just 15 years and above that can take the Xifen-M tablet. For your asthma patients, please note that it's not a replacement for their medications. It can be used hand in hand. It's not a replacement. So whilst they are on Xifen-M, you don't need to adjust the dose or change the dose. They can still take their asthma medication whilst taking Xifen-M as well. For drug-drug interactions, generally there's unlikely drug-drug interactions, but it should be avoided with alcohol because alcohol can increase the sedation side effects of the levocetirizine in Xifen-M. So I want to talk about a few clinical studies that Xifen M. The first was a comparative studies between levocetirizine and desloratadine. It was found out that levocetirizine has a higher specificity to the H1 receptor, and it also has a faster onset of action and greater consistency as compared to desloratadine. And it's also faster, it has a faster onset of action and a faster time to reach steady state plasma concentration. Another study by the Allergy Asthma Immuno Research, they did a research where they compared two groups, the levocetirizine Montelukast group and then a plain Montelukast group, to check the comparison of, to compare how symptoms of nasal congestion and rhinorrhea are decreased. So from the first table you see, the yellow group is the levocetirizine Montelukast group, and then the red is the Montelukast group only. The first bars you see are the baseline, so that's when before they started the therapy. And then the last is 4 weeks after they started their therapy. And you can see from the 4th week that there was drastic reduction in nasal congestion with p-value for daytime nasal congestion. For the second group, it has a very similar one with p-value of 0.0381 for nighttime. Hence, there was drastic reduction of nasal congestion during nighttime in the levocetirizine Montelukast group. The last table is for rhinorrhea in the daytime. And again, the Montelukast levocetirizine group showed drastic and better results with a p-value of 0.0469 as compared to the others. So it shows also that the study was again very significant. The last research I'll talk about was a research that was organized for physicians and clinicians. And it was realized that the antihistamine and Montelukast therapy was a preferred first-line therapy in cases of allergic rhinitis. So from the table, you can see that out of 551 people, 84.39% had a preferable choice as for antihistamine and Montelukast as their first-line therapy. So this means that with the Xifen M combination, more physicians preferred it. So here are some unique features, which is a summary of all that I've said. I'll just go over a few. So Xifen M, it has less drug-drug interactions as compared to other combinations when taken together. It's also because of the levocetirizine and then Montelukast combination, they both work hand in hand to tackle both the early phase and then the late phase of allergic rhinitis. It also has very less sedating effects as compared to other antihistamines, such as cetirizine. Again, I mentioned that the levocetirizine is a prodrug, so it doesn't need to be metabolized. We also have it's being produced in a We also have it being produced in a GMP accredited facility under the license of Luex UK. Hence, you are assured of good quality of your product. Okay. So that's just a few of the unique features. Thank you very much.
Thank you very much. Now you invite Dr. Abdul Razak to introduce the chairman for the second scientific section. Dr. Abdul Razak is the Upper East Regional Secretary.
Good afternoon to all of us. After such a sumptuous lunch, I have the privilege to introduce the chairman for the afternoon session. I want to be as brief as possible because if I want to give all the accolades assigned to the chairman, I might spend the chunk of this afternoon's time. So for this afternoon, our chairman is an astute clinician, a public health consultant, a researcher, and a senior lecturer. He has backed a number of research publications in his closet. On the SPMDP front, he is currently the chairman of the Central Regional Branch. At the national level of SPMDP, he chairs the Health Insurance Specialist Hospital. I will conclude by saying, and I must admit, I'm only told, so if you have contrary information, please do not hold me responsible. But I'm told that he's happily married to only one wife, and he's blessed with 3 children. Ladies and gentlemen, kindly help me to welcome Dr. Joseph Somwa Ekwamwa Otumfuo. Mr. Chairman, you have your audience. Your audience here comes on stage, your chairman. Thank you.
Good afternoon, Dr. Razak. I met him first when we were having something to do with ultrasound. Then I said, this man looks very nice. Those days he was in public practice. Then I said, we need to be friends. And we have been friends ever since. About 10 years now. We're now studying ultrasound, so that we'll be able to scan our patients. Thank you very much for the nice introduction. Yes, I'm happily married with one wife. And only 3 children. Luckily, only 3 children. Because where I worked in Braunhavel, the temptation was very high. A lot. Ladies and gentlemen, this afternoon is going to be very interesting because we're going to discuss something which is very, very dear to our hearts. Prostate. 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 We're going to listen to people who have been doing a lot of work in this area. And I'm sure they will make the afternoon very lively. Ladies and gentlemen, let's listen carefully and then write our questions down so that we'll have a good interaction with them. Thank you very much.
Thank you, Mr. Chairman. Now, we are going to invite one very good Ghanaian. That is Professor Dr. Med Matthew Kwame Yamwa Chi. He's a consultant. One in Sheba Medical Center, Israel, and Stellenbosch University in South Africa, in uro-oncology. He is a reviewer of about 20 medical journals. He also doubles as a trainer and examiner of the West African College of Surgeons and the Ghana College of Physicians and Surgeons. His topic today is APT, Update on the Diagnosis and Management of Prostate Cancer. Ladies and gentlemen, with a round of applause, let's welcome the good professor to the podium. You're welcome.
Thank you very much. I'm glad to be here. I received a call from one of my teachers. I said, I'm sending you to Ho. I said, yes, sir. So Prof. Kwaku called me and said I should be in Ho. So I'm here. But I'm glad I'm here because I've seen some of my senior people and people who employed me first. I see Bishop Yaraba here. She gave me employment as a locum in their facility, opening my eyes to both academia as well as serving the people within your communities. We are looking at prostate cancer this afternoon. Just at lunch, we were discussing the fact that it has become quite an important disease in our environment. The reality is that it's a disease of the aging male. And so anytime statistical service says that the life expectancy of the man has increased, then prostate also follows and suit. So now life expectancy 61, 64 for the male means that a few more people will get it. For the median age for prostate cancer in our environment here is about 69 years, which means that about half of the people are below 69 and half are above 69 years. Most world literature will tell you that 1 in 8, 1 in 9 men will develop prostate cancer in their lifetime. In their lifetime. So if I decide to start counting the men here, good. But it's one disease that even though 1 in 9 or 1 in 5 in the African population gets it, a lot of people survive it. In fact, it's only 1 in 6 that will die from the cancer, which means that even though it's prevalent, yes, survival is quite good. We are looking at about 12, 17% dying, as compared to something like a breast cancer, which is about 35% chance of dying from it. So it's quite a gentleman, we will say, but quite unforgiving. Quite unforgiving. Okay. Good. And now, the age at which one gets it is important. Normally, if people get it at an elder age, below above 75 and 80 years, it tends to be a disease that is indolent. In other words, you may have the disease for a period of years, and a CVA or something will take you away and not the prostate cancer. And there are a lot of patients that the next time you see them, I don't see that again, so he had a stroke and he's gone. But the prostate cancer was under control. And so when you get it above 75, it's good. In fact, in current literature, a lot of people are indicating that maybe even after 75, probably you don't even need to screen for prostate cancer again if the person is asymptomatic. But unfortunately, there have been few surprises within our race. And so I would say that so far as you're alive, take opportunity to continue to check for it. But in the world literature, after 75, if you are asymptomatic, probably there's no need to do a PSA at all. But at the African population, we may have to look at this again. When we talk about prostate cancer, we're looking at a disease, as we know, a cancer, a localized disease, a locally advanced disease, and a metastatic disease. So the question is, how is the current presentation, 2006, 2005, 2026, 2025, how does it look like? I just look at a year's work, and you realize that out of about 37 cases that we looked at, a significant amount of them were actually localized disease, 27 out of the 37. And this is because of the screening that we are doing now. So almost every other lab, almost every other facility of ours is able to do the PSA. And that is a very useful test that we do. So we are picking them early. And normally for screening purposes, we do the PSA and the digital rectal examination together to arrive at a conclusion. Why do we do that? We do that because if the tumor is anaplastic or not that much differentiated, then they produce less PSA. So a PSA of 3.7, 4.2, and yet they have got metastatic disease, which means that that disease is very aggressive and is not producing the PSA as we expected. So actually, a higher PSA is a good news, that your tumor is more differentiated and therefore it's making out the products that it's supposed to make. But about 10 out of these are actually advanced disease or metastatic disease, and we'll talk about the differences that this brings on board. For the risk factors, we are familiar with them as trainers. But definitely the African race, a family history of prostate cancer, and probably smoking may be three things that we may pick up as very, very important in the risk factor considering prostate cancer. African race is a genetic marker. So our disease tend to get it early and it tends to be aggressive. So even after all the treatment, radiation, radical, you see the PSA still rising, and sometimes we lose patients even after these major interventions. Okay. So family, African race is important. The reason is because we have got high levels of testosterone and because there are some genetic mutations that we have inherited. Probably it offers us some advantages, but then when it comes to prostate cancer, it offers a disadvantage. Family history is also important. For family history, normally they tend to occur early in life and tend to run through the generations. So grandfather had it, father had it. In our books and current practice and research shows that if any person gets prostate cancer below 75 years, you must put on the hat of thinking of a family history of the prostate cancer. So you are 60 now, you are 62, 63, you must have a few questions about the family. But if you appear at 83, then probably family history may not be very important. We also talk about inflammation and healing. So prostatitis and other inflammatory conditions are also things that we can consider as part of the risk factors. And of course, the management of prostate cancer, especially the metastatic ones, is hinged on the androgens. The prostate is a reproductive organ, so it thrives on androgens. So the presence of high amount of testosterone is expected to drive the tumor. And probably that's one of the reasons why our African race, maybe we get a disease that is quite aggressive. But also realize that it's not enough to talk about the testosterone androgens, because we research have realized that our highest level of androgens is between 20 to 24 years in males. But we are finding prostate cancer above the 40 years. We are talking about a median age of about 69. That means that when our testosterone level is coming down, that's where prostate cancer is showing up. So we think that probably it's an imbalance, and we have identified a few receptors we think may be playing a role in that. Vitamin D, calcium, these are all things that we know, and a few things that has come up as a risk factor. I know we are familiar with these things. We are here for an update. So just to set up the ground rules, and they'll pick up a few things that have come up that we need to know. We said it's only 1 out of 6 that may die out of the cancer. And so there's some diseases of them that will not, you have found a prostate cancer, but then it was not going to kill them at all. And that is the reason why in other places the PSA test has become controversial. Because you find somebody walking, going to office, and then you find a prostate cancer. And you say, let's go and do radiation therapy, let's go and do brachytherapy, let's go and do surgery. And then in the course of the process, they get a complication and they die. In the course of the process, they get a complication and they are bedridden, become incontinent. Meanwhile, they will have lived for the next 10 years without any intervention at all. So the duty of us is to try and see whether we can position people as whether it's a latent disease or something that is critically significant, and we must chase it. Otherwise, and they may die from it. And that can be challenging to us. For histology, commonest is the adenocarcinoma. And most of our discussion this afternoon is looking at adenocarcinoma. In other words, you can find somebody who is 20 years old and has got a prostate cancer, but it's likely to be other histologies like a rhabdomyosarcoma or leiomyosarcoma, but not a prostate cancer. One of the things that we do for assessment is the digital rectal examination. And we also know that we do the biopsy, the transrectal ultrasound-guided biopsy. These are all hinged on the fact that if you divide the prostate, transversely, you may find I've got areas you call the zones. And this work was done by Dr. McNeil. And he realized that the peripheral zone is where the cancers were commonest, almost 70 to 75%. And the peripheral zone of the prostate, as an apple, is the part that abuts the rectum. So when you do a digital rectal examination, you are going to see about 70 to 75% of the prostate cancers filled it. Or when you do a transrectal biopsy, you are likely to hit 70 to 75% of these cancers. Now, that means that about 25 of the cancers may be difficult to assess from the transrectal route. So you will see that some of your patients, you send them to us, and we say that we are going to do a transperineal biopsy. Transperineal biopsy means that we are going to pass the needles between the scrotum and the rectum, because per our assessment, we think the tumor may be within the transition zone and the anterior zone, which are middle. And so when you approach it from that side, then we are able to do that. So generally, before the MRI came into being, especially in our part of the world, we used to do that for those who have done multiple biopsies and it was still negative and the PSA was still going up. So PSA 12, biopsy negative. PSA 18, biopsy negative. Then PSA 26, 37. Then we may consider the transperineal on the assumption that probably it is in that zone that is not assessed from the peripheral zone. But with the advent of the MRI, which we'll talk about, now we are able to assess that right from the beginning. We can decide that for your disease and where the lesion is supposed to be, the transperineal route is preferable for you. So that's how transperineal biopsy came into being. But we found out that it has another advantage, and that is less infection. For some of us, if we have kind of prostate biopsy, we gave you a lot of antibiotics to take. And when we had a fever, everybody was running helter-skelter. So we realized that when you do the transperineal, infection rate was quite low. And so we felt, okay, now, in most parts of Europe now, they just do the transperineal. Not because you can assess most of the cancers, but because the infection rate is very low. But I must say that somebody did the work in Brazil and realized that if you add iodine, betadine, to your gel in doing rectal examination or smearing the rectum and do a biopsy, the infection rate is as good as the transperineal. So now most of the biopsy we do transrectally, we add betadine to the gel that we use. And now infection is not a big issue. In fact, we do biopsy, we send you home the same day, and nobody really asks of you. Previously, we give you a number, we call you to find out whether you are well or a primary line because infection is low. So there's a local disease, infiltrative disease, and metastasis. The best or the common area of metastasis is through the lymph nodes and to the bone. So most of our assessment is looking for lymph nodes and looking at the bone. So after the bone, they may go to the lungs, they may go to the brain, and they may go to anywhere else. So if you don't find a lymph node or the bones, then we are confident to say that this is a local disease or a local advanced disease, and we can treat it appropriately. So all the tests that we do, the bone scans, we mentioned them, are all aimed at staging. Find out whether there are anything in the lymph nodes or in the bones. Then that will help us prefer the kind of treatment that will be useful to the patient. So we do a biopsy, we see that you have written adenocarcinoma of the prostate. The next thing we'll see on the report, which you are all familiar with, is the Gleason score. So the Gleason score is just telling us the pattern that we see on the slide, how close it is to the glands in the prostate. And we have scored it from Gleason 6 to 10. If the Gleason score is 6, then it means that this is a well-differentiated cancer. If the Gleason score is 7, we say it's intermediate. And if it's 8 to 10, then we say it's poorly differentiated or anaplastic. So if your Gleason score is 8 or 10, then we want to treat you aggressively. If you leave you alone, you may succumb to prostate cancer. Maybe 1 out of the 6 that will suffer for you. So we are looking at the histology and we are looking at the Gleason score. So please, let's pay attention to the adenocarcinoma, because if you come back and it says adenosquamous or it's squamous, the treatment is different. It's different completely. Okay. We are also familiar with the prostate-specific antigen, PSA. It's a hydrolase which the body puts into the bloodstream, just to remind us that its purpose is to hydrolyze semen and allow the sperms to be released from the semen coagulum so they can go to the fallopian tubes to fertilize the ovaries. But some of them spills into the bloodstream. The normal is 0 to 4. Now, the 0 to 4 is a universal number, but based on your age, we can't manipulate it. So you are 75 to about 80 years, we move your number to about 6.5. And if you're above 80 years, we may look at it from about 10 as your normal. So the age is extremely important to us, as well as the rate at which it increases. So we not only look at the total figure, but we also look at the rate of increase as well as the age of the patient to be able to interpret it. But other diseases can cause it to go up. The BPH, cyst, prostatitis, and everything else. For one of our residents did the work and realized that the average PSA for BPH in the studies that he had was 8.8. So people had 13, people had 5 and 6, and they were still BP. So we don't look at the PSA alone and make up our mind. The last study we did, we realized that if the PSA is between 4 and 10, the chances of finding prostate cancer is just about 20-22%. So within that group, 1 out of 4 may be prostate cancer. 3 out of 4, 4 out of 5, there's no cancer at all. So we look at the PSA, but we don't necessarily run with it in that particular way. Good. Then some of you may have seen free over total PSA. It's another way of looking at the PSA. It comes in 2 forms. The free one is not bound, while the compressed one is bound to microglobulins and albumin and other chymotrypsin. When there's cancer, PSA from cancer tend to be very sticky. So it tends to be bound to these microglobulins so that the complex is small. So if you divide the free by the complex and the small, in other words, a big denominator and a small numerator, then what you have is likely to be a cancer because the majority of the PSA you find is the bound form, which is the typical one you find from prostate cancer, than from the prostatitis that we have found. So we look at the PSA, but we've done a few manipulations to be able to help us that. There's the prostate antigen 3, it's in the urine. We are not using it very much because it is not sensitive. What it means is that you can have prostate cancer and you won't find it in the urine. But it's very, very specific. If you find it in the urine, then there's a prostate cancer. Then you must look for it. Very, very specific, but not sensitive. But we tend to use that when you have to do the multiple biopsies. But because of MRIs, now we don't use it as much more. Then we mentioned prostate-specific membrane antigen. This compound has been known for a period of time. But it has become a very important compound for us. So these are transmembrane proteins that stick on top of the prostate cancer cells. It doesn't shed them, but we can tag them. So we have got the PSMA, SPECT scan, and PET scan that identify these molecules attached to the cancer cells. And so we use it to identify the lymph nodes and identify the bones as we go on. For the clinical presentation, you are familiar with this, so I wouldn't bother you. But in the local disease with the low initial symptoms or local advance with the blood in the stools, tenesmus, constipation, some of them come with hydrouretus and nephrosis because the ureters are involved. Some of them have erectile dysfunction. Some of them come with retention of urine because the whole urethra has been infiltrated. And some come with hematuria because the bladder is involved. So depending on the surrounding anatomical organ that is involved, then the symptoms may be. And of course, once it has spread, they can have the bone pain and other things that we are all familiar with. We've talked about the digital rectal examination already, so we won't speak much about it. So the biopsy. Every histology, this one we're talking about cervical cancer, every tumor, we need a histological confirmation so we can be able to grade it well and also find out which chemicals or which medications could be most useful. So we talk about the transrectal ultrasound guided biopsy. We do it by the bedside, office procedure, and we take different areas of the prostate, about 10 to about 12 areas, sampling the prostate, because the tumor is relatively quite multifocal, and so that is it. So we take about 1.5 centimeters, and the pathologist will then report on it for us. Then we mentioned the transperineal, which in most parts of Europe and America is taken over, but they still continue to perform it because this requires a form of anesthesia. Normally, we do it here using the spinal or the caudal block. And one person did something about a month ago in the UK, and he tells me it's so painful. They did it local, but they tell me that it's so painful. But we do it at the spinal. But in other places, they are doing it at the local, at the bedside. But histology comes in 2 weeks, and they said it's a prostate cancer, and then we have to go on and manage very well. An important update in current management of prostate cancer is the MRI, what's called the PARAD score. So the MRI, you run the prostate or the MRI through the prostate, and there's a diffusion, manipulations with a lot of measuring the blood flow and everything else. And that allows you to classify a lesion in the prostate into parad 1, parad 2, parad 3, parad 4, and parad 5. For some of us who are familiar with breast cancer, they also have their Barrett scale as well. So if the MRI says that the lesion of prostate is 1 or 2, then it's likely to be a benign disease. The chances of finding a cancer on biopsy is less than 10%, less than 5%. So PSA is 5. MRI says it's parad 2. We may decide to watch you. PSA in 6 months or PSA in 1 year, just to look how it behaves. If the parad is 4 or 5, the chance of finding cancer is about 30% and high, and that is too high to gamble with. So PSA is 6, PSA is 7, and then MRI gives us parad 4 or 5, we will do biopsy. Because lucky that a tumor there may be clinically significant. Okay. 3 is indeterminate for most races. But I think that we are doing a few more work on how to determine our 3, because some of our 3s have ended up being malignant. Some of our 3s have ended. So we want to look at 3 again, but probably may swing other way. So we want to look at 3 again. But generally, 1 and 2, we will sit tight. 4 and 5, we have to do biopsy. 3, we'll discuss your experiences and your wishes, and then we'll go by that. So now we have got a PSA, digital rectal examination, and the MRI with the parad score. There we are in a position to decide which way to go. So this, again, the MRI and this development. Then we come to, after we have made a diagnosis, we need to stage it. But we need a lot of tumor burden to be able to see that. In fact, we need about 50% of the bones being replaced before it can be seen. So we tend to do this for those with back pain and who cannot walk, But if we have to do critically, then we go for the bone scan. So we have got the bone scan, or what we call the technetium-99 bisphosphonate scan. So the bone continues to remodel itself, and it uses the pyruvate and then the phosphorates to do that. So if you tag this bisphosphonate as the body is remodeling, then it will show. In cancer cells, a lot of blood supply, a lot of cell turnover, so it tends to be what we call a hotspot. So if you look at this slide, all the dark areas represent areas that there is prostate cancer, because the bladder is showing, but all the bones and all the ribs. So this is a bone scan that is also available to stage it. The problem with the bone scan is that it's not specific. Anything that causes a lot of blood to flow to the bones, it will show as a hotspot. So Paget's disease, sarcoidosis, multiple myeloma, a healing fracture, they will all show. Osteomyelitis. So it made it difficult. And that is why the PSMA PET scan is very useful for us. So for the PSMA PET scan, it's also a radioligand. It's also using gamma rays and everything else. But if it shows, then it is prostate. If it shows, then it's prostate. So this is a picture showing you somebody with metastatic prostate cancer that is showing. Okay. But there will be a few deceptives. So we have some figures we give. More than 3, we'll discuss that later. But a few figures beyond which they will know that it's quite definite. So PSMA PET scan is available now in the Sweden Ghana Medical Center, but a bit expensive, but it can be very, very useful. It's wonderful, but sometimes it can be very, very traumatic. I had a patient, PSA 5.2, DRE, everything was fine. Biopsy, adenocarcinoma, Gleason 7. So, okay, let's do the PSMA and see. And then there was metastasis. And it was quite devastating for this 56-year-old man. Everything was local, we are planning local, and then bang, it's metastatic disease. And then we have to look at it. But we'll talk about how we look at metastatic disease in the current practice. Whole body MRI is also another thing that can be done. A normal MRI may take about 45 minutes for every session. So lumbar spine, pelvis. But this whole body MRI, ride the MRI through your body in about 45 minutes. But it's able to detect cancers in the bones as well as in the lymph nodes. So we are either doing bone scan, whole body MRI, or the PSMA PET scan, depending on the tumor volumes or the financial implications to the patient. But these are important to be able to decide whether this is a localized disease, local advanced disease, or metastatic disease. But we have the bone scan available in Ghana. We have the MRI, whole body MRI available in Ghana, and we also have the PSMA currently also available. So we can really be able to decide effectively your cancer and the way to go. Okay. So this is a PSMA PET scan, a patient there. You can see the yellow areas. That indicates metastasis. And for one patient, you can see that to the left, right, lower, it's just the sacral area that the tumor was found. And so we treat it as a metastatic disease. Why we are at metastatic disease? So previously, we have local disease, local advanced, and then metastatic disease. Now, the update currently is that metastatic disease, there are differences. We have those that the number of tumor sites are few, and there are people that the tumor sites are plenty. So we have divided the metastatic disease to what we call oligometastatic disease and, I would say, frankly, metastatic disease. For oligometastatic disease, what it means is that there are less than 4 areas or 4 or less areas of the bone involved. So there are 4 vertebrae or 1 rib, 2 ribs or something. If you count less than 4 bone areas involved, then you are approaching oligometastatic. You also look at the Gleason score, less than 8 to 10. So 7 and 6 metastatic, that is also good news. And then there must not be any involvement of any of the organs, whether liver or conventional metastasis. If you have got only the bones, Gleason score 7 or low, then oligometastatic disease. For these people, if you treat them with the anti-androgens that we give, the Zoladex and everything else, and you send them for external beam radiation, they live 8, 10, 12, 15 years. They survive and survive well. If they are above 75, most of them will live their own life completely. So oligometastatic disease is potential for newer drugs, 4 years, and then you are gone. So we are looking for those that we can extend their lives. So you can see somebody, you send a patient to us, metastatic disease, and next time around, he tells you that they send me to go and do radiation therapy. It means that we have classified the person as oligometastatic. And so we are treating it with the radiation and the hormone. Radiation alone is not enough, but radiation and the hormone. So this one patient is an oligometastatic because we found it only in the bones there. Once it's only the bones, then we know that this person, we can keep him in the next 5, 6, or 12 years alive with radiation and our hormone therapy. So there are a few guidelines, we won't go through them, but so how do we treat prostate cancer? So the question is, do we treat everybody that has prostate cancer? And that's the debate that is out there. The truth is that some prostate cancer, we call it low risk or favorable. The PSA is less than 10. The Gleason score is 6 or less. Now we normally have a minimum of 6. Okay. And the digital retinal examination shows that it's just a nodule. We call this low risk. And you can watch these patients. Watch it doesn't mean that you have washed your hands, but every year or every 6 months, they come for a PSA, they come for digital retinal examination. If you are not sure, you run the MRI through. If you still keep these parameters, then you can keep an watch on them. Sometimes every year or 2, you may repeat the biopsy. If the Gleason still says at 6, you can be able to keep them without doing anything to it at all. And I know people that we have been thinking of them for the past 6, 7 years. We have not done any treatment, just watching them. But it's a very tricky one. One patient we advised he should do that told me that, I don't understand you people. I was in church and they came there and they said I should do my PSA. Then I went to the PSA, biopsy, they see a cancer and they say you are not going to treat. So why did you come in the first place? But when you show them some of the treatment complications, they realize that it's good we have the knowledge, but we can still buy sometimes. So that is it. But beyond the low risk, then we try to treat. Any Gleason 7 or more, we want to treat. Any PSA more than 10, we want to treat, because if you leave them, they are likely to succumb to the tumor. So what are the options available? They are all available to us. Radical prostatectomy is surgery that takes the prostate, remove the whole prostate and seminal vesicles. It's very effective. Very, very effective. I've had the privilege of attending a few 80th birthday celebrations 10, 15 years after surgery. They've had their full life together after radical prostatectomy. It's good for those less than 65 years. Probably solely the best, because you get your full life back. The next 30 years, 20 years, you get your full life. So young patients, localized disease, radical is extremely useful. Of course, got its side effects. Urinary incontinence sometimes, erectile dysfunction, sometimes bladder stenosis sometimes. But by and large, it offers a better cure when you are younger than 65. You have got the robotic approach. That has shown to be a bit advantageous because you see they are magnified. You see better, you can spare some of the nerves, continence is better. So it's a bit more superior compared to the OP. But the cancer control is the same, but a bit more superior because it's magnification. Your bigger your screen, the bigger you can see. You can see every nail, every nerve. So it's quite a useful thing. We don't have it in the country yet. I know efforts are being made to bring it in the country, but people go to South Africa, India, Canada, and do have it. And it's very good results if one can afford it. Again, curing this completely. So that's the robotic one. Very, very magnified, depending on the size of your skin. Then we have got the radiotherapy, the external beam radiotherapy. So currently, the radiotherapy in use is the conformal. I've seen a radiologist here, so they understand it better. It's the conformal or the image guided. And so you can focus completely. And it's very, very effective. External beam, very, very effective. But I prefer that for those above 65 years because the radiation itself can induce cancers. We have seen people with bladder cancer and colorectal cancer after radiation therapy, after about 10, 15 years. So if you do that for 56-year-old or 60-year-old, by 72, they have another cancer from the radiation. So even though it is less invasive, less morbid, and people prefer it, oh, I've done my radiation, yet the long-term outcomes may not be as good as preferable for the younger people. But if you are 69, 72, it is as good as the surgery, because we are all looking for to be 85 or 86, and the radiation will take you from 75 to 86. So it's a cure in its right sense of it, and it's very good. Then you have got the brachytherapy, where we put seeds into the prostate to try and control the disease. Okay. When it came on Verge, we were doing it for everybody, and we lost a few prominent people from brachytherapy. The truth is that brachytherapy is only for what they call the low-risk disease. So PSA around 10 or less than 10, the Gleason 6 or 7. A small prostate less than 40 grams or 30 grams. It's very, very strict criteria. Okay. So if you don't follow that criteria, I've got brachytherapy, by the next 3-6 years, you realize that it's going up. Okay. But of course, we realize there's a problem. So now we combine brachytherapy and external beam. So instead of asking the patient to go 6 weeks on external beam, you do the brachytherapy and then we cut it down from 6 weeks to, let's say, 21 days or 17 days. So it becomes an adjunct. So a fraction of the radiation is given as a brachytherapy and another fraction is put on as external beam. And when you're getting between 8 and 10, PSA more than 15, prostate slightly more than 40 grams, then we'll go for that combinations. Just counting on the reducing the frequency of attendance rather than tumor control. But when you combine the two, and in the last 5 years that it has been published, you realize that it's quite better. It's making the brachytherapy much more acceptable than initially practiced. So radical prostatectomy, external beam radiation, brachytherapy, or a combination of brachytherapy and external beam radiotherapy. And these are refreshingly cure for those who are a bit elderly. There are a few other therapies. Cryotherapy is available. We don't have it here. Radiofrequency, folk ultrasound, and cyberknife. Unfortunately for us as Africans, it's not work very well. But those in the European race and Asian race seem to work very well. Our team is very aggressive. A few of the people who have gone to Germany for some of these things, unfortunately, we've lost a few of them because it's not very effective. So it's quite, we'll still in our books call it experimental, but I think for the African race, I wouldn't do that. I've got a few people for American soldiers, Ghanaian soldiers in America, or Ghanaians in American forces. And one of the things was that any African prostate cancer, they did cyberknife. And I had a few of them that I had to send back and write a letter, look, their disease is coming back. But more like a research. They signed for it anyway, cyberknife, but 2-3 years' time, the tumor started coming up again, and they need to be dealt with. Good. We've talked about surveillance already, so I'll leave it that we discussed that already. Okay, we've talked about this. Good. So I had to do a presentation for the West African College. So I decided to sample urologists across the West African region about whether they did active surveillance. Generally, many people did not do that. And we have a lot of reasons. Patients are afraid, I may lose patients, they may go out, they may not come back, and everything else. But this shows the kind of practice now. We give a 16-year-old Gleason 7, PSA, gets a PSA, less than 10. What will you do? And we realize that in our region, most people will go for the radical prostatectomy. But sometimes, because of the lack of the expertise of the radical prostatectomy, even though in their heart they wish we are doing radical prostatectomy, they tell you go for radiation therapy, just because probably they don't have the skill to offer what is really best for the person. Good. So we've talked about this already. Locally advanced disease, oligometastatic, metastatic disease, and then the whole body MRI, PSMA, and bone scan are the things that we do. We've discussed all of this already. So good. We talked about this already. Yeah. Then for metastatic disease, anti-androgens is what we use. So we are going to reduce the production of androgens. Okay. Testosterone is one of the androgens, but there are other androgens as well. So you realize that about 90-95% of the androgens are from the testes, but the adrenal cortex also produces some androgens as well. Okay. About 5% of them. So when you talk about androgen deprivation therapy, then you must look at how we brought the testes and the adrenals to be very, very effective. So if you do only orchidectomy, you are leaving out 5% unattended to, and that can be the cause of the problem. So right from the hypothalamus to the pituitary gland, to the adrenal glands and the testes, and to the receptors at the end of the prostate or other organs, we try to block them. And I'm sure you are familiar with all these blockages. So currently, we know that orchidectomy alone is not enough, because if you do that, one arm is gone. So there's two arms there. The testosterone, the left gives us testosterone from the testes. The right is adrenal. If you do only orchidectomy, then you are only dealing with the right part, but you're leaving the left undone. So we try to combine. So currently, for metastatic disease, it's fire on all cylinders. So we call it escalation or de-escalation therapy, or intensified therapy. So it's not enough to give only Zoladex. No. So we do Zoladex, we will do abiraterone, we do chemotherapy, what we call triplet. We fire on all cylinders. And then as time goes on, we can escalate. So in our current practice, monotherapy is not accepted. Because when you do the combination therapy, life expectancy move from 3 years to about 5 years, 5.5 years, almost 24 to 48 months more. And so currently we are fond of therapy, but it's damn expensive. And so sometimes people start it and then they even abandon the monotherapy. So we look at it from that perspective. So we talk about orchidectomy, and it's, yeah. So you are familiar with the LHRH agonists, the leuprolide, the glycerin, which acts on the hypothalamus, others agonists and antagonists. We heard about the diastebesterol. These are all things that we are familiar with. The newer ones are the ones that inhibit the synthesis of testosterone. So here about abiraterone. Now there's Zatiga, there's Barato. There are a lot of innovative generic ones coming on the market. Hopefully, it could help us on. There's enzalutamide. Apalutamide has just been registered. Darolutamide, we don't have it yet. But the idea is that now it's orchidectomy plus these ones, or Zoladex plus this one. You fire on cylinders, and you are likely to get 2 more years on the life of the patient than running on only one cylinder. There's also the intermittent therapy, where you give the person for about 1.5 to 2 years, and then you wait. If the PSA goes past 5 or 10, then you put another injection in. And you are going to feed people that every year they come for one Zoladex injection, and you have been doing that for the past 6 or 7 years, because once the PSA goes past 10, you give a shot, it brings it down to 3 or 4 or 0.2, they go for another year. The next time they come, it's 15, you give a shot, and they tend to do very well, because it's quite very useful. You confuse the tumor. When they think everything is all right, you are rejoicing, and then you come and clear them, and it can be very useful, cheaper, more tolerant, and it's make it easier, especially the elderly people. So children don't need to keep going to Boboasi and bring their father, or going to, a while to bring their father. Once a year, they come and get a shot, and then they are gone. We've talked about all of this already. So we are saying that currently it's 3 cylinders. The normal one, the orchidectomy, the Zoladex, the leuprolide, the abiraterone or enzalutamide, or darolutamide that is newer on the market, and then chemotherapy, especially for the younger people, if they have metastatic disease. Then, with time, a year or 2, you can de-escalate. So we call it the intensification treatment, other than the ballet treatment or the triplet therapy. I said we are struggling to adapt it because of the cost involved. But in most parts of the world, that is standard of care. There's also the PSMA radioligand 171 lutetium. Now, this is still based on the PSMA, but it destroys cancer cells that have found themselves into the prostate, that have found themselves into the bones, sorry. So this is a radioligand. If you inject it, it goes and attaches whatever the tumor is and then burns these tumor cells. So those with severe back pain, if you give it to them, within a day or two, realize that all the pain has virtually disappeared because all the tumor sites have been virtually apoptosed by this tumor. It doesn't offer survival advantage. No, you still die at the 3 years or the 5 years or 5.5 years based on the standard therapy that we have. But bone pain relief is extremely useful. I know that currently, we used to send people to South Africa and India for it, but I think I just saw a mail from Sweden America said that they are now ready to do that 1 year. So severe bone pain, either you're going for radiation therapy, if it's a localized area, radiation on them can help reduce the pain. You can reduce your morphine and everything else. But if it's systemic, the bones in the head, everything else, then 177 lutetium is very, very useful and it's available. It's quite expensive. I think it was $7,000 per shot. Those going to India, about $15,000, South Africa. But I'm sure when it comes to localized, it's likely to be cheaper. But it can make pain disappear as if they don't have a metastatic disease. The others are genetic testing. Now we decided we can test the genetics, and there are a few drugs that can be very useful based on the genetics. But I always say that for us as Africans, we have been genetically mapped up. So if you're looking for that genetics, we are just going to add it to our African skin. We are already genetically mapped up for aggressive disease. So if you find out more, then we are just amplifying the genetics. But some genetic markers can allow some other medications to be more effective than others. Good. Immunotherapy is available, but I think the lutetium will take away from Cipro-T. Cipro-T, very expensive, mainly for local advanced disease. But I think lutetium will take over. This will disappear very, very soon, if not disappear at all. So genetic testing is just to find out whether there are any other changes that will enhance a particular drug. Because some of the drugs are tested based on genetic lines. So you can see that based on the genetic profile, maybe enzalutamide is better than abiraterone. Maybe darolutamide is better. Maybe BTO will be better. So the genetics is just helping us look at which one will do much better on the treatment that are still available to us. No new treatment. What we have, can genetics help us predict what option we should choose for you? So we mentioned the de-escalation. Hit it hard, a year or two, and then you can relax on it. They can get 2.5 more years more than going slow and do a second line when it has failed. When they fail second line, when you put them in, it doesn't change the equation at all. But when you hit hard, then you are likely to get the advantage. Okay. So there are a lot of studies on that. So I said these are all based on research and guidelines that are available. So what I've just done is to bring out a few things that have happened. So the first thing is the race share issue. It's still an important thing for us. That we Africans, please, we shouldn't treat our prostate cancers with gentleness, no. Because it kills, and it kills. And I'm sure all of us here can tell 1 or 2 people. I've virtually managed my own teachers, and they've died from metastatic prostate cancer. They taught me about prostate cancer, but the prostate cancer killed them. So it can be very aggressive in our race. The next one is age. Is the person less than 65 or more than 65? If the person is less than 65, the surgery is preferable. If they are more than 65, then radiation and surgery are on the same footing. You can allow them to make their advantages. But if the family, we live to 93, 92, and want to get them 20 years born, then surgery is preferable. The radiation has its own side effects as well, so it's not as cost as this. 70 and above, I think radiation therapy is quite useful. Because sometimes you do surgeries and then the heart will fail. And then good surgery, then cardiac arrest, and then they are dead from a heart attack rather than from the surgery that you have done. So I think above 70, I will go for a radiation therapy. Brachytherapy is nice, but please, it is very limited room unless we are doing the combination. Most part of the world now is the combination that we use. Okay. Good. Then we talk about the MRI with the PARAL score. And we say that the MRI with the PARAL score happens to look into the prostate that we used to do before. So PSA, digital rectal examination, and the MRI. Especially those who are PSA below 10 and you want to see whether we should proceed or wait, the MRI can be useful. PSA is below 10, DRE, just a little nodule or feels benign, MRI 1 or 2, part 1 or 2. Look, 6 months' time, I've got a few people that they are coming in February, January to do PSA again. Because after the assessment, we think we can keep an eye on them. But they can't leave our site. Because if the PSA passes 10, we have to do something about it. The advantage of the MRI is also that it also localizes where the cancer is. So the cancer is the anterior zone. So right from the beginning, we say, look, for your prostate cancer, we are going to do transperineal. Because where it is, transrectal, we will not be able to assess it. And so that has also been very useful for us. Then we also talk about the treatment. Where now metastatic disease, we are grouping it into oligometastatic and metastatic disease. Oligometastatic means that when you bring in the bone scan, when you bring in the PSMA PET scan, when you bring in the whole body MRI, we are going to count the areas that there are tumors and look into the lymph nodes and the liver and see whether there are tumors. If there is no tumor in any of the soft tissues and it's only the bones and it's less than 4, we are going to send you for all the hormone therapy, de-escalation, whatever we are going to do, but we are going to put radiation on it. Because really, what kills them is the hydronephrosis. What kills them is the retention and catheter and change of catheter and urosepsis. And then, constipation and spiritual diarrhea. These are the things that kills them. So if you're able to silence the local that is going to kill them, then they will live longer. They will not get the hydronephrosis, they will not get the hematuria, they will not get the urosepsis because of catheter. And so it makes sense that when you do that, you are taking some of these confounding issues out of them. Then we say that it's escalation, triplet or binary. Zolades plus abiraterone Zolades, enzalutamide, Zolades, dolutamide. And if you are a younger person, 54, 56, Zolades, enzalutamide, docetaxel chemotherapy, triple therapy. Hit hard. Then you can relax, and they are likely to get 5, 6 more years than before. And we said for bone pain, is the lutetium. 177 lutetium has been very, very useful for us. You give it as injection, it goes and attacks any area from the brain to the toe. Any area causes apoptosis, a death of tumor cells, and the pains will all disappear. But it doesn't offer survival advantage. They still die within the period that the tumor will run its course. But a lot of pain relief. So in summary, this is what you have been doing, just trying to bring you update. I know you've a lot of information, but let's tell you a few things that are happening online and what is available for us to offer. But I'll say it again that it's a deadly disease. We had all the opportunity to be treated, but somehow we have to bury them. So please, let's give ourselves a chance. But don't run ahead of ourselves and treat everybody that we see. Then we cut some people's life also short, unnecessary. Thank you very much.
Another round of applause for the Prof. Prof, thank you very much. The chairman has told me that we will take questions after the second presentation. Dr. Digor Moses Dobache is here. He's the CEO of the Medimosis group of companies. These include the internationally acclaimed Medimosis Clinic and Prostate Center. And they have 5 such branches in Ghana. Many people think the guy is a herbalist. He's better than that. He's a trained medical officer. He trained at the School of Medical Sciences, KIUST. And then he worked as a medical officer at the Komfanoche Teaching Hospital to the rank of a senior medical officer. What did he do? When he got to the rank of senior medical officer, he went back to school, to the KNUST School of Pharmacy, and got an MPhil in pharmacognosy. Then he also trained in traditional Chinese to specialize in plant medicine. He has received several international awards for his field, the field of plant medicine. Today, he's going to discuss with us the new dynamics of cancer management, the role of herbal medicine. He's the only guy who can do that. And he's here. So if a round of applause, let's welcome Dr. Digor Moses Dogwachi. Dr. A, you are welcome.
Hello, everybody. Good afternoon. Yes, so the new dynamics of cancer management, the role of herbal medicines. Cancer is one of the most dangerous diseases all over the world after heart disease. Cancer is the main cause of death. Various factors involved in cancer development, which may include environment, lifestyle, genetics. It is well established that despite the increase in technology and modern therapeutic methods, cancer is still a major global challenge. Various novel treatment methods have been developed for cancer treatment and are available in high-income countries. However, these advanced and novel treatment methods are not available in low-income countries like Ghana. Given the significant health and economic burden this disease imposes, it is important to explore more effective treatment strategies. A major drawback of conventional cancer therapy is the persistence of drug resistance, adverse reactions to chemotherapy, digestive damage, reduced quality of life, and high treatment costs. To address these challenges, researchers have been investigating the utility of using complementary and alternative medicine alongside conventional cancer treatment. Some of these and reduce the severity of adverse effects from conventional therapies. Cancer refers to any one of a large number of diseases characterized by development of abnormal cells that divide uncontrollably and have the ability to infiltrate and destroy normal body tissues, and often has the ability to spread throughout the body. Cancer is the second most common cause of death worldwide. According to the World Health Organization, cancer accounted for almost 1 in 6 deaths in 2020. About 1 in 4 people will develop cancer at some point during their lifetime. Of cancer is mutations or changes to the DNA in the cells. Genetic mutations can be inherited. They can also occur after birth as a result of environmental forces. These external causes, called carcinogens, can include physical carcinogens like exposure to radiation and ultrasound, UV light, ultraviolet light. Chemical carcinogens like cigarette smoking, asbestos, alcohol, air pollution, contaminated food, and drinking water. Biological carcinogens like viruses, bacteria, and parasites. Types of cancer. Cancers are named for the area in which they begin and the type of cells they are made of, even if they spread to other parts of the body. For example, a cancer that begins in the lungs can spread to the liver and still be called lung cancer. There are also several clinical terms used for certain general types of cancer. We have the carcinoma is a cancer that starts in the skin or the tissues that line other organs. Sarcoma is a cancer of the connective tissues, such as the bones, muscles, cartilage, and blood vessels. Leukemia is a cancer of the bone marrow which creates blood cells. Bone marrow which creates blood cells. Lymphoma and myeloma are cancers of the immune system. As I said, the main cause of cancer, I've said this already. Okay. Now let's move on. Now, symptoms of cancer, the general symptoms of coughing up blood or bloody mucus, unusual lump or swelling. Experiencing these symptoms may not necessarily mean you have cancer. Now, treatment options. The most common types of treatment are surgery, chemotherapy, radiation therapy, stem cell or bone marrow transplant, immunotherapy, hormone therapy, targeted drug therapy, clinical trials, and then we also have the complementary and alternative medicine, which I'm going to focus on today. All what I've said already, you already know. But what I'm about to say will be something new to all of us. God, in His own wisdom, has provided solutions to every problem that will be created. He knows it from beginning to the end. If you believe it in your heart. God knows everything, and there's no wise man on earth which is wiser than God. And that is true. We are scientists, we are researchers. But when you see what God has done, has already put in place, you always praise God. Now, the role of herbal medicine in cancer management. In other parts of the world, they look at the method they use to treat cancers or other ailments. It's not the same thing that the Western medicine uses. Western medicine teaches us certain aspects of treatment. When you go to other countries, their treatment is vastly different from Western medicine. Traditional herbal medicine and medicinal plants have significant role in new drug development, particularly for cancer and other infectious diseases. Phytochemicals with diverse chemical structures and various therapeutic properties are the major ingredients of many newly developed drugs. Research on natural products and herbal drugs explains their significance for infectious diseases and cancer. Natural products, especially herbal medicine, have been studied for their healing efficacy against various human ailments, and it led to investigation and separation of a variety of phytochemicals with proven biological properties. In the case of cancer therapy, around 60% of anti-cancer drugs we are using now, including vincristine, vinblastine, mention them, docetaxel, all of them comes from herbal medicine. 60%. They take the herbal medicine and then synthesize it, get one bioactive compound out of it, synthesize it and multiply it, and then try to use it. That's the Western method. The plant they are isolating one compound from contains more than 10,000 different bioactive compounds, which work differently. But when you select one and try to synthesize it and use it like tissue specific, organ specific, it will achieve the results you want, but causes side effects. Because the body does not exist in separation. It's a whole body, holistic, as a one unit. So the approach should be looked at differently. In case of cancer therapy, around 60% of anti-cancer drugs are originated from their natural products or their derivatives. Various standardized herbal extracts are also being used for the management of and improvement of quality of life for cancer patients. The role of herbal medicine in cancer management. To assess the role of herbal medicine in cancer management in Ghana, we will examine the following: the use of traditional herbal medicine in various parts of the world in cancer management. We'll look at Japan, we'll look at India, we'll look at Korea, we'll look at China. How are they doing it? And they don't do Western medicine. For information, they don't do what we have been taught in school. That's not what they do. They do something different from Western medicine. Something entirely different. We also look at herbal medicine, which contains components that aid in cancer management in Ghana. Advantage of using herbal medicines for cancer management in Ghana. We also look at that. And the role of stakeholders in promoting herbal medicine in Ghana. Now, so let's look at this. Traditional medicine used in other countries in cancer treatment. In China, where I studied traditional Chinese medicine, I was in class and the professor was teaching. Because whatever the professor was saying doesn't make sense to me. It doesn't make any sense to me. Because what I know is not what he's telling me about diseases. He's telling me something different about diseases. He said air causes diseases, water causes diseases, fire causes diseases, and all that. I know bacteria, viruses, and all those things, but you are telling me something different. So if you're not careful, you tend to argue with the professor all the time that what he's telling you is not the right thing. But that's what they have been practicing for more than 5,000 years. And it's working for them. It's working for them. So there's something true in there. So we want to find out what is in there. Traditional Chinese medicine has a long history of cancer treatment, which has been evidenced by the classical literature of Chinese medicine. Numerous studies have shown that combining TCM with other conventional cancer treatment can enhance the survival rates of cancer patients, improve their quality of life, and stop the growth and spread of cancerous cells, which we all dread of, is the spread. That's why we are looking for a way to stop it. Hanging is an important form of TCM that is being used for the treatment of cancer. The diagnosis and treatment of tumors were discussed in ancient traditional Chinese medicine texts like Yellow Emperor's Inner Canon more than 2,000 years ago. The major concepts of TCM are regulating body immunity. The major concept is regulating body immunity, eliminating pathogens, and treating both the symptoms and the root cause of the disease. That's their principle. TCM has been reported to enhance the effectiveness of radio and chemotherapy by strengthening the spleen and stomach, nourishing the liver and kidneys, and eliminating toxins from the body. TCM combined with chemotherapy has shown promising results in improving efficiency with fewer adverse side effects. During the last several decades, it has been shown that TCM is effective in cancer therapy, demonstrating minimal toxicity and improved efficacy as an adjuvant to radio and chemotherapy. In India, whose practice is also different from the Western practice that we know, Ayurveda is an Indian ancient healthcare system originating in the Vedic times around 5,000 years ago, and is one of the oldest traditional medical systems with holistic approach to health, dealing with various aspects such as prevention, diagnosis, treatment, and detailed personalized regulation of food, nutrition, and diet as per the individual constitution, what they call Prakriti. In Ayurveda, cancer is defined as inflammatory or non-important and basic factors involved in normal functioning of the body, according to Ayurveda, such as the nervous, which they call Vata, or air in English, the venous, which they call fire, and arterial system, which they call water. That's the apparatus. According to Ayurvedic system, in the case of malignant or cancerous tumors, these three basic systems are out of control. These factors lose mutual coordination, which leads to tissue destruction, resulting in critical condition. The therapeutic efficacy of an Ayurvedic herbal medicine, herbal formulation, depends on the multiple phytoconstituents extracted from the raw plant drugs. Bioactive compounds are reported to act as epigenetic regulators that modify gene expression. Various phytoconstituents of Ayurvedic medicinal plants might be capable of reversing epidemic aberrations during carcinogenesis. The reversal of epidemic aberration might be helpful in cancer treatment without adverse side effects. So when we look at this, the Ayurvedic medicine or the herbal plants, we say that regulation of oncogenes and tumor suppressor genes, these herbs can do that. Elimination of cancer stem cells, the herbs can eliminate cancer stem cells. And they can also arrest cell cycle so that the cells that multiply in cancer, they will arrest it. And they also cause inhibition of angiogenesis. They will stop the blood flowing to the cancer cells so that they will not have food or nutrients to continue multiplying. In Korea, traditional Korean medicine has been in practice to treat various ailments for many years. The Joseon period, 1392 to 1910, saw the creation of the first encyclopedia of Oriental medicine, which summarized Korean Oriental medicine. Later, Sansang constitutional medicine was established based on the principles of medical tradition. So, to cut a long story short, it means that different parts of the world have different approach to treating cancer. Different approach. In Japan, for instance, the traditional Japanese medicine, popularly known as Kampo medicine, was originally developed from ancient Chinese medicine established during the 16th and 19th centuries. In Japan, Kampo medicine can act as polypharmacological therapy, and hence each Kampo formula can address multiple symptoms. Supportive cancer care was officially incorporated into treatment schedules in Japan following the establishment of the Japanese Association of Supportive Care in Cancer. Now let's come home. Let's come back to Ghana, which God has endowed us with a lot of herbal medicine, millions. And because we're not trained like that. We're not taught like that. We've been taught differently. And there are a lot of plants. Today, I will only limit myself to only 3 of them. Only 3. We talk about Coquimba longa, that you know already, turmeric. It's a home that everybody here knows, turmeric. We also talk about Allium sativum, which is garlic. Everybody knows garlic, and all of us eat garlic. But do we know what it contains? You know what it can do? We don't. And we talk about Pseudocedrella koichi. I'll just limit myself to only 3. There are a lot of them that can handle cancer, any type of cancer. And I'm going to tell you how they do it and how God does it. Not God made them do what they do because God knows what cancer can do and God knows how it can fight cancer. Now let's talk about Coquimba longa, turmeric. Everybody knows turmeric. Coquimba longa, commonly known as turmeric, is a herbaceous plant belonging to the ginger family. The plant produces a variety of secondary metabolites, including flavonoids, alkaloids, tannins, and phenolic acids, among which the active hydrophobic polyphenol diferrulumamantane named curcumin is of special notice. Curcumin is used in the treatment of various health conditions, including inflammatory disorders, liver diseases, metabolic syndrome, neurodegenerative diseases, and most importantly, several types of cancer. This is the chemical structure of various types of curcumin. The structure consists of two aromatic rings connected by a chain of carbon atoms with various functional groups. These can be modified to create derivatives with elevated biological and pharmacokinetic properties. The derivatives indicate potential modification to the curcumin structure, suggesting the versatility of this compound. Now let's look at curcumin and select only cancer. We want to see how the curcumin can work its cancer cell growth. Curcumin suppresses the uncontrolled multiplication of cancer cells by interfering with their signaling pathways responsible for cell proliferation, including WNT/beta-catenin, PI3K, AKT. These are signaling pathways. Signaling pathways in every cell. Before the cell do anything, there are signaling pathways in every cell, from the mitochondria, the response, how they can multiply. These are all ways the cell work to multiply. But turmeric or the curcumin has the ability to stop it so that you don't multiply and proliferate to become plenty, like cancer. So we have a lot of signal pathway. You can just Google. All what you see, the WNT, beta-catenin, is a whole topic on its own. So you can just Google, if you have a phone now, Google and see what it all means. The JAK/STARS, they all have different ways of working. And these are all God's doing. It's not anybody's doing. Only that we didn't know. We didn't know. That's why we are just hustling. Trying to find ways. But these are all there. This slows tumor growth and reduces the ability of cancer cells to survive. 2, it induces what we call apoptosis. That's programmed cell death. One of curcumin's most important anti-cancer action is its ability to trigger apoptosis. Apoptosis is, the cells will be born, and then after some time they have to die off, and another one will be created and they will die off. That's the way God arranged the things. But some cells decide not to obey the body's instruction, so they keep on multiplying without stopping. That's cancer. That's cancer. They won't obey, they will grow uncontrollably without taking any instruction. So what the curcumin does is to make sure that it induces apoptosis. Also activate pro-apoptotic proteins, what you call BAX and caspases. And then they suppress the anti-apoptotic proteins such as BEL2 and survivin. Apoptosis is regulated. You can either hasten it or delay it or suppress it. So when the mitochondria works, then you're able to multiply. But if it confuses the mitochondrium, you cannot multiply, so the cancer cell will die. Unlike conventional therapies or chemotherapy, curcumin tends to have greater selectivity towards malignant cells, while causing comparatively less damage to normal tissues in preclinical studies. 3, it causes cell cycle arrest. The cell cycle have a certain cycle, they have to multiply and multiply, and you have to intervene stop the multiplication. Cancer cells divide uncontrollably. Curcumin interrupts this process by arresting the cell cycle, particularly during the G2/M phase, preventing cancer cells from completing division and producing new tumor cells. And they also suppress tumor angiogenesis. Tumors need the blood supply, then they will grow. In God's own wisdom, you have to limit the blood supply. You have to cut it off so that they won't grow. So tumors require new blood vessels to open oxygen and nutrients. Curcumin inhibits angiogenesis by reducing the vascular endothelial growth factor, VEGF. They also HIF-1 alpha, and then another signal pathway, PI3K, AKT. They are all signal pathway, and they are very detailed things that you can just read. If I want to talk about it, you don't have time to finish. 5, they also prevent cancer invasion and metastasis. Curcumin reduces the spread of cancer by inhibiting epithelial mesenchymal transition. They lower the matrix metalloproteinases, MMP2 and MMP9. They also reducing migration and invasion of cancer cells. They reduce the migration and invasion of cancer cells. And then 6, they reduces chronic inflammation. These are all persistent inflammatory contribute to tumor initiation and progression. Curcumin inhibits major inflammatory mediators, like the one listed. They also act as powerful antioxidants. Curcumin neutralizes reactive oxygen species and oxidative stress, including DNA damage that may initiate cancer. Interestingly, within cancer cell, it can also increase the ROS beyond tolerable levels, selectively promoting cancer cell death while sparing healthy cells under many experimental conditions. They also induces ferroptosis. Ferroptosis is different from apoptosis. Recent evidence suggests that curcumin promotes ferroptosis, a specialized form of ion-dependent cell death, distinct from apoptosis. It does this by increasing intracellular ion, increasing lipid peroxidation, decreasing GPX4, and decreasing glutathione. This represents a promising strategy against cancer that resists conventional therapies. It also modulates immune system. Curcumin helps restore immune surveillance by reducing immunosuppressive cytokines, enhancing T cell activity, reducing regulatory immune cells that protect tumors, improving tumor microenvironment. These effects may improve responses to immunotherapy. And number 10, it enhances chemotherapy effectiveness. One of the strongest conclusions of the review is that curcumin works well in combination with standard cancer therapies. Review reports synergistic effect with cisplatin, 5-fluorouracil, docetaxel, paclitaxel, and all that, all the therapies, the chemotherapies that we know, it works well with them. Potential benefits include increased tumor sensitivity, reduced drug resistance, lower chemotherapy doses in some settings, and enhanced apoptosis. What I've just said, we got some clinical evidence, some research that has been done in a study revising curcumin in cancer, Khadija et al. According to the review article, curcumin has demonstrated anti-cancer activity against multiple cancer types, primarily through laboratory studies, animal models, and limited number of clinical trials. The strongest evidence of cancers were where curcumin inhibits cell proliferation, induces apoptosis, suppresses angiogenesis, it may help manage prostate cancer, breast cancer, colorectal cancer, pancreatic cancer, liver cancer, ovarian cancer, cervical cancer, typhoid cancer, glioma, neuroblastoma, a lot of cancer that curcumin can help, esophageal cancer, and all. Now, clinical evidence in humans. The review highlights that human clinical evidence is strongest for pancreatic cancer. A phase 2 trial reported clinical benefit in a small number of patients, including one with prolonged stable disease and another one with a marked tumor regression when treated with high oral doses of curcumin. It can also help in breast cancer, like I said, multiple myeloma and colorectal cancer. The conclusion on longer. Curcumin, an inactive hydrophobic polyphenol extracted from the rhizomes of the plant Curcumin longa, has been investigated thoroughly and has exhibited an important role in the treatment of various conditions, including several types of cancer. As shown in the review, curcumin targets multiple signaling pathways involved in initiation, development, and growth of tumors. Growth factors, transcription factors, protein kinases, cytokines, and genes taking part in apoptosis are the molecular targets of curcumin, which appear to significantly affect the development of different malignancies. However, in vitro studies and clinical trials in humans are needed to determine the complete mechanism of action of this compound in each different type of cancer, while ensuring safety for human use. Now let's come to what we also know again, Allium sativa, garlic. Now garlic is a member of a Linaceae family. It's a globally consumed food and is bestowed with immense medicinal benefits. Numerous research findings have attributed these health benefits mainly resulting from the organosulfur compounds such as alanine, glutamal, cysteine, and their derivative. Besides these organosulfur compounds, garlic is rich in trace elements, zinc, magnesium, copper, selenium, iodine, protein content, dietary fiber, vitamins, ascorbic acid, and polyphenols. Historically, almost all civilizations in the world had knowledge of the medicinal benefits or medicinal properties of garlic. And garlic has been used in treating a variety of ailments, including leprosy, diarrhea, constipation, infections. However, garlic as a potent anti-carcinogenic came to light in the late 1950s. After Weisberger and Pensky demonstrated that thiosophanes extracted from garlic possess anti-tumor properties. With the therapeutic potential of garlic and the advent modern analytical techniques, there has been a surge in garlic research by many research groups around the world. Now let's look at the main component that helps in fighting cancer. These are all derivatives of allicin. And these are the chemical structures. Now, allicin is a natural product from chemically on crushing a garlic clove. It is unstable and transformed into a variety of bioactive secondary metabolites, as I've already shown. And these are their chemical structures. Now, this one, disulfide, called DART, a compound composed of two allyl groups connected by two sulfur atoms, is a vital organosulfur compound that's found in garlic and helps in the mechanism of action that garlic produces. There are a lot of slides. I just want to have said the major things. And this is also an anagion, which is also isolated from garlic. Let me just mention a few clinical evidence based on research on the study of garlic. A study entitled Updates on the Anti-Cancer Potential of Garlic Organosulfur Compounds and Their Nanoformulation, Plant Therapeutics in Cancer Treatment by Pratibha Pandey et al. These were the results they concluded through clinical evidence. Garlic supplementation reduced breast fibromatosis with benign breast disease. Garlic consumption was encouraged among breast cancer survivors in a randomized controlled trial. Garlic also reduced docetaxel clearance in individuals with CYP3A5 1A allele. suggesting a potential interaction with chemotherapy that warrants careful monitoring. In patients with advanced lung cancer, and colon and pancreatic and liver cancers, 2 grams a day garlic extract for 12 weeks increased both the number of activity of natural killer cells, indicating improved immune function. In colorectal cancer, aged garlic extract inhibited colorectal cancer, colorectal adenoma growth in a large randomized trial involving 57,500 participants. Long-term raw garlic consumption was associated with a reduced risk of colorectal adenoma. It also helped in gastric cancer. In conclusion, garlic is one of the most powerful food used in many of the civilizations for both culinary and medicinal purposes. Garlic contains bioactive substances that have substantial anti-carcinogenic effects via a number of pathways, including cell cycle arrest, apoptosis, stimulation of angiogenic cascade. The nutritional and the therapeutic benefits of garlic have been well known. Among numerous phytoconstituents of garlic, certain compounds, including what I've said, SAC, allicin, and all that, have strong cancer activity. Now let me talk on the last one, which we don't know much about. It's called Pseudocedrella koichi. Pseudocedrella koichi is a plant in our own environment. We have it around us. And it's also very effective for cancer. In fact, in Medimosis Prostate Center, that's one of our powerful drugs we use to treat cancer. We have it in formulations, in a capsule form, in a tea form. Now, Pseudocedrella koichi is a medicinal plant whose therapeutic value, no doubt, has a folkloric background, and it has been used in treatment of various diseases by traditional healers. In Togo, the root bark of Pseudocedrella koichi is used in treating gastrointestinal diseases, rheumatism, and febrifuge, whereas the roots and the leaves are used to treat dysentery in Nigeria. Various extracts of the plants have been reported to possess anti-diabetic, anti-epileptic, analgesic, antipyretic, antimicrobial properties. Other biological activities reported for the plants include anti-noroceptive and anti-inflammatory and in vitro growth inhibition of schizon stage of Plasmodium falciparum. Now let's look at these very plants in cancer management. The supplementary review provides the strongest new evidence by highlighting activity against 4 human prostate cancer cell lines, which was not covered in detail in the earlier experimental paper. Researchers investigated aqueous root extracts, and then these cancer cell lines were, all these 4 cancer cell lines demonstrated a dose-dependent reduction in cell proliferation and viability, with inhibitory concentration 50 values ranging from 12 to 45 microgram per mil. They cause apoptosis. The extract also induced apoptosis in all these cancer cell lines found in prostate cancer. The significance of these findings, the findings indicate that Pseudocedrella koichi may suppress prostate cancer cell growth, reduce tumor cell survival, stimulate programmed cancer cell death. It also, in breast cancer, it has an effect on breast cancer. The studies show a remarkable activity against these cell lines in breast cancer. It also has effect on cervical cancer and then ovarian cancer. Skeletal muscle cancer, the earlier study found that the root bark of skeletal muscle cancer cells were sensitive to the stem bark ethyl acetate fraction, isolated stem bark saponins, and then stem bark saponins exhibited an inhibitory concentration value of 5.28 microgram per liter per mil. Now, active components in Pseudoxanthella. We found that there are certain active components that act as principal anti-cancer constituents. Limonoids is the major active constituent of Pseudoxanthella. More than 30 phytochemicals have been isolated with limonoids and triterpenes. Predominating important limonoids include all that as listed with quercetin, guanine, and all that. These are limonoids which are acting in a way to help fight cancer cells. Why limonoids matter? Limonoids are primarily responsible for the plant's anti-proliferative effect through interference with key cancer survival pathways. Now, among the limonoids, the review highlights quercetin A to H, particularly compound 4, as having the strongest biological activity. They bind strongly to heat shock protein 90. They inhibit prostate cancer cells. They inhibit breast cancer cells. They inhibit ovarian cancer cells. One of the most important discoveries reported in the review is the inhibition of heat shock protein 90. Heat shock protein 90 is an essential for the stability and function of many proteins that promote tumor growth, including this kind of tumor that is listed below. Because many cancers depend on HSP90, inhibiting this protein can disrupt multiple cancer promoting pathways simultaneously. Reviews propose that HSPC90 inhibition is a major mechanism underlying the anti-proliferative effect of Pseudoxanthella coechi. Experimental studies demonstrate that saponins are among the most potent cytotoxic constituents, particularly against breast cancer and cancer cells. These compounds likely contribute by inhibiting the cancer cell proliferation, inducing cell death, and reducing tumor cell viability. These are all compounds that are found in the products. So studies indicate that Pseudoxanthella coechi is a promising source of anti-cancer phytochemicals, particularly limonoids, including the quercetins, guanines, and all that, and saponins. And the evidence supports activity against prostate cancer, breast, cervical, ovarian, skeletal, and muscle cancers, which particularly strong finding in prostate cancer, where the extract exhibited cell proliferation and induced apoptosis across 4 distinct prostate cancer cell lines. The identification of HSPS90 provides a plausible molecular mechanism for anti-proliferative effects. Further studies and clinical evidence are needed for absolute proof. Thank you.
Thank you, Dr. Dubachi. I told you he's the only one who can handle such an issue. Now it's time for questions. Please, you raise your hand.
Thank you so much, the two presenters. It's been a very refreshing.
Kindly introduce yourself.
My name is Regin. I have 3 issues for Prof to help me understand. Prof, when you were highlighting at the beginning of the presentation and in your summary, you mentioned clearly the workup, the pathway to the diagnosis of prostate cancer. You mentioned PSA, digital rectal examination, MRI. I want your opinion for the rural practitioner. Does transabdominal ultrasound or transrectal ultrasound still play a role in the chain to the workup of diagnosis of prostate cancer? That's number 1. 2, Prof, you mentioned orchidectomy as one of the adjuncts to the treatment of prostate cancer. In your practice, your experience, what is the level of cultural acceptability of orchidectomy, which is popularly known as castration? And the third one, the last one, is there still a role for what was known as prophylactic prostatectomy for people, individuals with high risk genetic predisposition to prostate cancer? I'll be very glad if you can help me out with some of these concerns. Thank you very much.
Thank you, Dr. Razak. 2 more questions for the first group.
Thank you very much. I am Dr. Foley from Tema. My question goes to Dr. Dubache. In his delivery, he mentioned some countries like China, India, and this state, where herbal medicine is mostly used in the management of cancer. I would like to know from him whether in these countries they add surgery to the treatment. Then the second point is, I would also like to know from him whether he would like to advocate the use of surgery and herbal medicine or herbal preparation in the management of prostate cancer. Thank you.
Yeah, Boati is my name. I want to ask Dr. Dubate, for a little bit clarification. In using the plant medicine, especially the last one that you did, the plants, the leaves, the stems, and the roots, and we all know that they contain a lot of chemicals. And then sometimes you get one chemical that is very active in whatever specific thing that you want, to know and to use in treatment. And then at the end of the treatment, the patient might have got another problem with the other chemical constituents in those plants. May I know whether, in the course of, using these plants, for the treatment, you take into consideration the other active ingredients which may cause other problems for the patient, whether you abstract them or you abstract the correct chemicals, that are very, to be used for whatever treatment you want to do. Do you abstract them and segregate them from the other chemicals in the plant?
Dr. Dejakong, you can take your question.
Thank you very much. My name is Dr. Kwesi Odoi Ejahakum. Okay, let me say it well. My name is Dr. Med Kwesi Odoi Ejahakum.
Amen.
Amen. My question goes to Dr. Dubache. The problem I have is I am really confused because the lecture has been like a lecture at a postdoctoral. So I was expecting to hear new dynamics, but I didn't hear anything about new dynamics. Number 2, I'm a scientist, and most of you are scientists. My work has mainly been in research. And scientific research is very, very specific, We start with looking for something, we look for the methodology, we try it, and see whether it has worked or it hasn't worked. But if we come to say that it works just because it is written here and then written there, etc., these are all anecdotal talk or evidence. So far as I'm concerned, I haven't heard any single proper scientific research that validates almost all the things that were said. That is my problem. So if you have some very specific scientific research that give us a positive attitude or a positive answer to what we are talking about today, let's have a list. I love going back to read about these things. Please, thank you very much.
Thank you. The facilitators will answer your questions now. But let me remind everybody that we are live on the internet, on Facebook, and on YouTube. So smile a little bit.
Thank you very much. Yeah, good. Yeah, thank you very much for the question. Good. So we mentioned, he was asking about the algorithm or protocol for making a diagnosis of prostate cancer. So we mentioned the PSA and how we look at it. We mentioned the digital rectal examination, and we mentioned the MRI with the power score. We have always been looking at something less invasive. So ultrasound was one of the things that has been looked at critical to see whether we could use it in this diagnosis. Unfortunately, generally, it doesn't work well because the tumors could be hypoechoic, isoechoic, hypoechoic. In other words, you see something, you say it's tumor, you biopsy, it's not tumor. You see something, you say this is too like a stone. You find out this is a tumor. So it has not been very useful. However, if there are tumor extensions, like hydronephrosis, they can say, this tumor, if it's a BPH, I'm expecting to see bilateral hydronephrosis and maybe some retention of urine. But there's no retention of urine, and yet I'm seeing hydronephrosis on one ureter. They can make inference that maybe there's something growing and it's impinging on that ureter. Of course, make inference based on the male and the age. So it's not been very useful at all. In fact, it's on that the MRI came. Actually, the development of MRI sponsored by the UK government was actually to replace biopsy. So that when you do the MRI power score, they don't need biopsy, they start treatment. But I realized that, again, the performance was not as perfect as expected. So you become an adjunct now. So generally, ultrasound has no role in the diagnosis of prostate cancer. It only comes in when you are going to treat. Like we said, brachytherapy says if it's less than 30 grams, it's perfect. 40 grams is allowable. So then we are looking at what's the size of the prostate so that we can know what to do. And for something like brachytherapy, the number of Cs you put in depends on the size of the prostate. So based on the size, we can decide we are putting 17 or 32 seeds. So that's what I would say. So here about heterogeneous and ill-defined, normally we look at them, but generally a DRE performs better than the ultrasound. But MRI is good. But the bottom line is that a biopsy is important, whichever way now. So none of the images replaces biopsy. Biopsy stays strong. Then the question about BTO. I mean, culturally, it's quite difficult. I mean, it's quite difficult. Sometimes BTO, people have to go and come severally, before they finally accept it. Those that we are able to do are those who come with complications. So they have gone paraplegia, they can't walk. And they tell you that when I do this one, you can be able to walk. And you get one or two people to testify that it was done and they could be able to walk. Then you can be able to convince them to do that. So because of that, you see us going back to diethyltestosterone, which was causing some DVTs. So we stopped it. But now we are going back to diethyltestosterone with aspirin and clopidogrel. And that is much acceptable to most people. So it's quite a difficult thing to offer. Prophylactic prostatectomy. It's come up severally. I remember the late Dr. Broby, Professor Dr. Broby, he told us that it's no excuse at all to say we can't do it. We just have to perfect our art. Because we're discussing, say that the complications of the procedure side that we want to find a life-threatening issue and deal with it because of the erectile dysfunction and incontinences. But he said we should perfect it. I know one or two people who have had the surgery done. But at the end of the surgery, not in the country, at the end of the surgery, the report says, and we found a small prostate cancer. They needed to cover themselves because ethically and globally, it's not accepted. But like you're doing for breast, there are some people that I think they may benefit from it. But as I say, we watch closely with them, MRI, biopsies. I know people have done about 3 or 4 biopsies because the family history is strong. And they want it to be removed. I don't think medical directors will be happy with us if we cause harm when there's no tumor. But it's something that I'm sure will come. We need to perfect the art of management of localized prostate cancer. And it's not only surgery. Maybe the cyber knife, maybe the brachytherapy, the radiation. You're able to perfect some of the things that we do, and don't expect a potential, the catastrophic side complication. It will be acceptable. But they are doing for mastectomy. I think we need to come there because there are people that are 42, 43. I can count about 6 medical doctors. 42, 43, 47 had to remove radical, PSA 86, biopsy, but we had a biopsy prove it. But they were very young. And they came because the family history were very strong. And they are happy people now. Some of them are consultants now. They seem very, very happy that it is out. Thank you very much.
Thank you, Prof. The first question was whether other countries add surgery to their practice. The answer is no, they don't add surgery. That's the way they manage their cancer patients. So the other countries like Japan, China, they don't add surgery because that's the way they practice to take care of their cancer patients. And the second question was asking whether I would advocate for herbal medicine or surgery for prostate cancer. The questioner asked that whether I would advocate for surgery or herbal medicine for prostate cancer. You see, we want to give everybody a reasonable alternative. In cancer management, there are a lot of ways, there are a lot of new novel ways of treating. So when you make the position known to the patient, you make the patient have an informed decision. We have this option. What we do at Medimosis Prostate Center is to give you the option. But we always prefer the non-invasive procedure. So we prefer to treat with herbal medicine that works. In fact, we've been following a very prominent patient who had a very aggressive cancer diagnosed in India, aggressive prostate cancer. At that time, he was 61 years. Now he's 78 years, and he's still strong. The prostate cancer has been confined to the prostate gland. It has not moved out. Recently, he went back to India to go and check. When he came back, he was so happy that they were surprised that what is he doing differently that the cancer is not spreading. For 17 years, it has stayed where it is. Our method, our approach to treatment is to make sure that we target the cancer cells, stop it from multiplying, hasten its death, apoptosis. The means that he used to even cause metastasis, we stop it. There are herbal medicine that does that. I've just explained a few of that to you. So for the past 17 years, he's a very prominent person. He's been going outside the country to all the countries to go and check, US, China, India. And he always come back with good news that when they checked, they were surprised because they were thinking that for 17 years by now, the way they diagnose is very invasive one. It's still confined and it has not moved. So we are doing what we are doing and we are getting the results we are getting. And people like to have different options. So we are offering a reasonable herbal alternative. That's what we are offering. Thank you. And then the last questionnaire was talking about a new dynamic to cancer management. This is the new dynamic I'm talking about. This one, I think most of us have not heard about it. So it's a new dynamic I'm adding to the topic given to me is the role of the herbal medicine in managing cancer, the new dynamics. So that's what I try my best to talk about. But if I want to go to methodology, we won't close today. If I want to go to all the methodology, that this thing, there are a lot of it. I can just humbly, the questionnaire, I can humbly refer you to some of the research so that we don't waste time here. The methodologies, everything is there. Maybe I went through it fast because of time.
But so if you want to know more about it, I'm always available and give you more information. Thank you.
Thank you. You go for a second round of questions. Any questions online? Not yet, okay. Dr. Aye.
Thank you. I am near Port Medical Center in Tema. My question goes to Dr. Dubachi. Rather interestingly, I was expecting you to tell us something about cocoa powder. Of course, in the world, if you look at the pricing, there must be something of worth. For I know it doesn't cure a cancer, but there must be something in the cocoa powder which is related to managing cancers. I would like you to tell us something.
Aduko Amia, Bolga, Upper East. Yeah, Prof, I'm still not satisfied with the ultrasound problem. Because urologists normally ask for such ultrasound after operation, before operation. Can you throw more light on this ultrasound business? It's not part of the examination considered when you're determining cancer. Thank you.
Yeah, Dr. Duarte, I think I'm back on my feet. I think my question was not answered. You know, the reason why I asked that question was that in a normal orthodox medicine, you know, all the orthodox medicine that we are using were all original chemicals, you know, in them. And then we pinpoint the one that is usually, you know, useful for, you know, certain disease condition. We abstract, look, chromatography, we check, and then we abstract the plant, you know, the chemical from the plant. And then, you know, pharmacologically, we try, you know, on tissues to see how it works. And then after all these things, that it comes out, you know, that like the orthodox medicine that we are using. And sometimes, you know, we knock down, you know, to doing semi-synthetic, and now we go to synthetic. Semi-synthetic because we see the plant structure, the chemical structure. And then the side effects that is being causing, we try to play around it and put some one atom here and there to be able to take away the, you know, the problem, the side effects, to reduce the side effect. That's why I wanted to ask that in the other, that's why I'm saying that one chemical may be good for a particular you know, purpose. But I wanted to know whether, you know, you abstract that one out of the plant for the treatment, or, you know, despite, you know, all the other chemicals that in it, you know, you still maybe dry the plants, the leaves, and, you know, formulate it into another dosage form for it to be used. And that's why I wanted to say that in the course of that, won't those chemicals affect, at the end of it all, affect, you know, the patient's outcome, you know, because you may treat maybe, like you say, you know, prostate cancer, but at the end of it all, the other chemicals might have caused another, you know, deadly, you know, outcome for a patient. Maybe, may not be no, but the patient, you know, have that problem. That's the reason why I was asking whether you abstract it.
See, it's just like what I was saying at the beginning. You see, they are all alkaloids. And that's why at Center for Plant Medicine, they don't try to differentiate the medicines, but they use a solution. Now, if you take something like quinine or quinine, depending on where you come from, when you go to Papua New Guinea, for instance, like some of us did when we were kids, we use neem tree as chewing stick when you get up in the morning. So in Papua New Guinea, it was discovered that people really had malaria in those days. And the research revealed that they always were chewing neem tree as their chewing stick in the morning. But then most of them were developing palpitations and heart problems. just because quinidine, which will cause the palpitation and the heart problems, is just a mirror image of quinine. So they were advised to stop taking. That's why proper quinine was extracted out of the whole thing and was or it's still being used for the management of malaria. This is what we are trying to talk about. Talk about certain things that we believe might have an effect or a bad effect on some other people. That's why we're talking about any scientific data. Because this quinine thing and the quinidine came out because people started having problems. So if you don't have scientific data and we continue to do all these things, we may be harming people instead of helping them. That's what we are trying to find out. That's all. Thank you.
Thank you. Our facilitators will answer the questions now. Prof.
Yeah. Thank you very much. Yeah. So, what have we been doing in making diagnosis of the prostate? We do what we call a temperate biopsy. So we divide the prostate into about 6 different zones and pick pieces from each side of them. We do that because we realize that, as you said, the tumor is multifocal, but the ultrasound is not able to tell us where the cancer is. So far as the current ultrasounds are, they are not able to tell us that there's a cancer in the prostate. German developed elastography, looking at how firm, how molecules moved. It didn't stand the test of time. So do the MRI and look at the contours of where the tumor is. Then when you do the transrectal ultrasound, then you imagine where the tumor was on the MRI. Then you can target it as well, because the ultrasound alone is not able to do that. Now there are software that will combine both. So when you put the ultrasound there, it can be able to mark the area for you. So far as prostate cancer is concerned and all the research over the years, ultrasound is only the size that has found to be useful as to which method you are going to use. But if you want to use to target a tumor, then the best we have come now is the MRI ultrasound fusion, depending on the power of the MRI and acknowledging the weaknesses in the ultrasound. So when we ask for ultrasound for prostate cancer, then we are just asking for the size. Of course, the other complications said hydronephrosis, a chronic retention of urine, a post-war residual urine. These are all things that we do because we want to manage the patient. But so far as identifying a tumor in the prostate itself, so far as current is concerned, we have not found it. Because the tumor can come in different shapes and situations. Unless it's a T4 that the thing is moving all over the place, several vesicles are involved, then you can hear the guys that, there's no, the edges are ill-defined. But even when they try to say ill-defined, sometimes you find out that the tumor is still confined. So we had wished the ultrasound can do the things we are saying. But unfortunately, over the years, it has not been able to do that. So it has not been able to do that at all. Yes. It's the size and the complication, the hydronephrosis, the stone in the bladder, the bladder tumor. These are the things that we use the ultrasound for. But for prostate cancer, the best so far is to do a fusion biopsy, recognize its weakness in this particular area of prostate disease, and capitalize on the strength of the MRI to do the MRI ultrasound fusion biopsy. But on its own, it can be very deceptive. No. Thank you.
Hello. So I'll take my last question first. It's the first time I was answering, I didn't answer it. So we were asking, there are multiple compounds in every plant. That is true. In each plant, you can find a lot of compounds, thousands of compounds in one plant. And each of them does so many different things in the body. The effects of one can cancel out the effects of the other. So we have a lot of compounds in the body, in the plants. The food we eat, the kotomre we eat, the cabbage, there are lots of compounds in it. The cocoa powder you mentioned, there's a lot of compounds in them. Now, what we try to do is not try to isolate a compound. If we isolate a compound and synthesize it, it's no more so natural, like God presented it to you. And herbal medicines have been used for ages, hundreds of years. And people know the effects of certain medicine, like we mentioned cocoa powder. We've been using cocoa powder for years. Now, you want to isolate something from cocoa powder, you know the benefits. It has several benefits. Several. For the heart, for the nervous system. It has benefits. So when you are taking it as natural product, you take it wholly. In China, when I went to China to study, I went with one pharmacist from Kolebu. We were in the same faculty, and he had malaria. That was in the early 20s, 2004. So yeah, you know, artesunate was isolated. Artesunate was produced from a plant, one single compound called artemisinin, which was found in a plant called Artemisia annua. Artemisia annua is a plant, but the Chinese produce artesunate from Artemisia annua, a single compound called artemisinin, and they name it artesunate. The artesunate came in the early 90s when it was very effective for malaria. We were using it for malaria. That was the drug of first choice for malaria. By the close of 2000, artesunate developed resistance. And we have to go back and find, to add lumefantrine, to add some other compound to be able to fight the malaria parasite. You know, for generations, if you are using the artesunate, the malaria parasite, they know which one affects them, which hydroxyl group or which chloride group, which group on the structure that is killing them. So with time, they've developed resistance to it. It's also happening with antibiotics. It happens. Now, the plants which they isolate the Artemisia annua from, the artemisinin is isolated from the Artemisia annua. When you go to China, the hospital where I was working, when you go to China, they don't have artesunate there. So my friend got malaria. We got out from campus. We were in center of Beijing. We went from pharmacy shop to pharmacy shop looking for artesunate. And none of them know about artesunate. Apparently, artesunate to ask our professor that my friend, we think that he has malaria. And we wanted artesunate because that was the drug of choice in Ghana. And the prof told us they don't have artesunate in China. We should go back and ask that we want Q1 soon. So when we got back to town, we went to the first pharmacy shop. We say we want Q1 soon. It was all over the place. Do you know what they do? It was the plant itself that has been cut in pieces and placed in a brown envelope and clipped for us to take home and go and boil. And if you use this plant for more than 5,000 years, it has never developed resistance. And up to now, it has never developed resistance. But when they isolated only one compound, artemisinin, the malaria plasmodium found a way of making it useless. You understand? So our approach is to be very holistic. Use it the way God has given to you. God is the wisest. I mean, you cannot even describe as wisest. He knows A to Z. He knows everything. So when he gives you this plan, that it works, it will work. In fact, some plants are not friendly. They can be poisonous. Like you said, you were mentioning about the quinine, which was isolated from the neem tree. They single out one compound, quinine, and after some time, it developed resistance. It's not working anymore. And you said people were eating, chewing the stick and were developing palpitation. You may not know whether it's related or not. I don't have any idea about that. But what we do is to give you a holistic approach. We don't isolate the compound. We give it to you. And the way it will work, God has the way of it working for you. Because it's God's own method, God's own plant. When you isolate it, you may develop resistance after some time. When you single out a single compound, it becomes synthetic. And it becomes tissue specific, organ specific. And that's where more of the side effect comes about. So we don't isolate it. We prepare it. We formulate it. Not even one plant, maybe 1 or 2, 3, 4 plants. We formulate it the way it is. And we do chronic toxicity tests, acute toxicity tests. We check the liver function, the kidney function. We don't check it. They do it at the Center for Scientific Research into Plant Medicine or the KNUSC School of Pharmacy. They will have to check, cross-check the toxicity, the liver function, the kidney function, everything, before they send it to Food and Drug Authority for them to cross-check and make sure that what was done at the various institution is right, to cross-check. Before they even give you the go-ahead to approve it and give you certificate to use in the community. I hope I've made my point. Okay, thank you.
There's one online question from the internet. One. And the question is this: is there any concrete evidence of saw palmetto's efficacy in the management of BPH or prostate cancer? I think this one is going for Dr. Gubachi. Is there any concrete evidence of saw palmetto's efficacy in the management of BPH or prostate cancer?
Okay, so saw palmetto, around the world, there are different companies using it for management of BPH, but not for prostate cancer. For BPH, there are literature that shows that it works. There are literature, you can search for it. A lot of clinical studies have been done on it. So it works. But I don't know it's working for prostate cancer. Thank you.
Thank you very much. Let's give a round of applause to our presenters, please. We have our last presentation from M&G Pharmaceuticals. You have 10 minutes.
Good afternoon, dear colleagues. My name is George Boateng. I'm a pharmacist, a very old pharmacist. If you look at me, you may suspect my age, but I'm an old man. I'm coming to present to you on the two products that we have. We have Pilocam for piles, and then we briefly also talked about Roclon, which is for anti-D, those who are having the rhesus factors. You know, you have been seeing it, but they say what is interested to the blacksmith is where he always hammer the point, because there has been some fake Roclon in the system that if you are not aware, you know, you fall a victim, you know, for that. And then the fake ones that we have, you know, some of them contain just sodium chloride injection, and it will not have any effect, you know, on the patient. So we are starting with from you know, just to look a little bit about the anatomy of the rectum and how we have the swellings and the veins and where we need the Pilocam, you know, to treat the piles. That's where we normally say it. And then, you know, this is that's cross-sectional view of the rectum where you can see exactly what I mean. And we have got different types of piles. You know, the one which is inside, you know, and you treat it in another way. And the one that comes out, you know, that is treated that way. And the one which have been prolapsed, that means, you know, I've gone up advanced stage. And the one with thrombose, that is, you know, bloody, you know, that you need to be very careful and need surgery out of it. You know, the bowel, when you are emptying, the way you stretch your side, mechanical strain on your body and physical stress and all those things can cause, I mean, like I said, that gives off why the pile, you know, or the prolapse, and then, you know, to be infected, and then there will be a problem for it. We have treatment landscape. The level of treatment in about 3 ways. You know, consecutive topical application, And then we have got another level, targeted the internal, prolapse, and then the one for surgical. So we are going to treat typically the one for the inside, the level 1, the level 2 targets, by using of the suppositories. I know we have different types of suppositories. The rectal one, we have got the vaginal one, urethral one. But what we are talking about one is the rectal one, the rectal suppository. And you see that, missile. And that's what, is being meant for easy penetration. So what you have is that you wash your hands. After washing your hands, you remove the suppository. If it's soft, you have to put it in the normal fridge for it to be solidified. And then you lie down sideways, or you put your leg on a chair or something a little bit higher. Then you insert, and you will waste a little, for about 10 minutes. Then for this thing to be absorbed in the system, before you go out. And if there's any way that the person is wanted to, go out, to pee, then you have to repeat it, because about that time, if it's not within the 10 minutes, that means absorption will not take place in the rectum and the medication will not be released. So the person has to retreat. And you have to use it, according to how the physician wants you to use. But normally it may be about 1 or 3 times. But you shouldn't use it so many times. Other than that, when your body becomes sensitized to it, there's a problem. It will not work, and it gives you a problem. So the PillowCam is formulated with about 4 types of, medication inside. We have got the local anesthesia, which will suppress the pains, there, so that you'll be a little bit comfortable, because sometimes, sitting down will be another big problem, so that you'll be able, the local anesthesia will reduce the pain, you'll be able to sit down. Then you have got the hydrocortisone inside, that will attack the swelling, to reduce the swelling inside, so that, the blood inside one will be removed out. And then there's a tissue damage, and the tissue damage will be repaired by the oxide, the zinc oxide that we have there. And then the allantoin, also another chemical that will help you to build up and repair the tissue that has, gone out from that place. So in our PillowCam, the tissue that have been destroyed, we try it, like Udi Ahinka used to say, I will not tell you anything which I have not used before. I mean, as an old man, I have a problem, so I use it, and it works very, very well. It's 5, 10 inside, and then it's packed 5 in a suppository way. So that is PillowCam. And it's not very costly. The cash price is almost 20 Ghana cedis. It's not costly. And I know you have it in your clinic, and it will solve. You come back and tell your doctor, the suppository you gave me worked very, very well, and I want more. And I bet you it will work well for you. Then let me talk a little briefly about the Roclone. The Roclone, these are things I've talked already. I talk more than the slides. You see, it is trying to help us to alleviate the problem of this rhesus factor, problems that we have. And we know that when the negative mother has a positive fetus in the body, the mother's blood and vesicles inside will attack the fetus blood, and then it will produce a lot of antibodies that will go and attack the blood cells of the fetus. And because of that, science has come out that you use the Roclone. The Roclone is a monochloride preparation whereby it is rid of any chemical contamination or any contamination from the body or from a human being. And because of that, is the best, product that we use. And what it does, it forms a circle around the blood cells. And it's like when you are treating, the virus, so that the virus will not have a chance of coming out to cause the problem. In the same aspect, the blood vessels the blood cells are being covered, to not allow the antitoxins that the toxins that the mother's blood will produce, to affect the baby. So what happened is that when the mother's blood sees the blood of the fetus, it sees it as an enemy. So it will go and attack. In the course of attacking, it will produce antibodies against it. So the Roculon is there as a gap to protect the cell from the antibodies, to have an access, to them. In the course of that, it will protect the mother. And after it has, done its work, it goes out back to the spleen, and the spleen would, dispose of it. So at a certain time interval, you have to administer the drug so that you protect the mother. Because if you don't protect the mother, a mother whose this thing has not been found and is pregnant, first time he's lucky, he will go out of it. The fetus may not die in the uterus, because the antibodies, it's a cumulative effect. When you bring forth the first pregnancy, the molecular volume of the antibodies are too big. It cannot cross over to the placenta to go and attack the fetus. But the second pregnancy, the weight of this is very small. That is be able to penetrate through the barrier, and it will go and affect the fetus. So you use this one to take care of this maternal and then the fetus barrier problem that we have. That is Roculon going to correct it. So the Roculon, this is exactly what I was trying to say. The first pregnancy, the molecular weight of the antibody are too big. It cannot cross the placenta in the barrier. But the second pregnancy, the antibody that will be produced will be smaller body weight that it can cross and then go attack the mother, the children, red cells. So the Roculon is there to be able to take care of the cells, protect the cells, so that the mother will be free and the baby to be free, and you bring forth the baby who is not jaundice, who is not dying, no stillbirth, and all those things. But there are two types of this. You have the cardiopulmonary pathway that, the fetus bud is also taken care of, attacked, and then neurological pathway where the fetus is also attacked. But in all these ones, there are a lot of consequences. If you see the red, map, hydrophytaris and the connector, Roculon is there to take care of all those things. And as I said, if the work has done, after protecting the blood of the fetus, it will then go out from the system, to the spleen, will just eliminate it. And so at a certain time of this thing, you have to take, the Roculon. This map shows that there's a gap. About 50% of the women in the world, they are not having access to the Roculon. Simple because maybe we have not tested them, or the campaign is very low or something or so. Because of that, we have got a gap. And this gap, we are supposed to fill the gap to make the women over there who are not having access to Roculon. Now we have the Roculon. In the trip, in my village, they used to say that Obano di awumewu, and we never knew. And now these are some of the things that were killing the babies, but we never knew all those things. Now the gap is 50%. We have to close the gap and making sure that, a lot of these women have an access. But if you do not know whether the woman pregnant has not got this thing, if you give the Roculon, it will not have the baby or the mother. It's a matter of protecting. If you don't give and the mother is negative and the baby is positive, then it's going to be a problem. But if you don't know that the mother is negative and the baby inside, the fetus is positive and you give, it will not have any effect of the woman on this thing, because everything will be okay and the woman will be protected. Then it's going to be a problem. So we have got risk factors, and that we have to clear it out of the system. So at a certain time of treatment, the mother, this is what I would say, this is what we have. The Roculon is the best one It's a human product, and it's a recombinant DNA technology that they use, and it's very, very accurate. There's no failure that have been recorded so far, and it's very well documented. This one is a comparison of this thing, and then showing that Roclon is zero specific adverse reaction. Roclon has got zero specific adverse reaction. And then there are some blueprints, as I was saying, that at a certain time, the mother is supposed to have a prophylaxis. And the 32 weeks, the woman has to get, this thing, or 34, weeks, the woman has to get the Roclon. And then after, postpartum, the woman is supposed to have the Roclon, so that, there will be any problem that you have. This is a routine prophylaxis, way of, that's a linear presentation. And this is what, if you have a problem, we have got a high priority, and then we have got a middle and a low priority. The high one, when somebody comes, you have got an ectopic. You may not know that, the person, the baby that the person was having was a negative, a positive, and the mother said no. You just give them, administer the, the Roclon to save the mother. And then the middle priority, abdominal trauma, and the other hemorrhageal procedures, that also will cause movement of blood from the mother to the fetus. Then you have to also to administer the Roclon at a certain point. And the low one is going to go amniocentrics. That's more invasive things that the gynecologist you go to attend the woman in the setting to get something. In the course of that, there will be a blood crossing from the mother to the into the fetus. And then you have to treat the mother, with Roclon. This was, as I said, it will not cause any problem for the mother. This is the Roclon. This is the Roclon that is being marketed in Ghana. M&G Pharmaceuticals is an agent for Roclon. Embara Serum and vaccines are the manufacturer of Roclon. And then M&G is the agent, the only agent in Ghana, no other person. As I said, there are a lot of Roclon on the market. Quite recently, FDA, somebody, from India, the manufacturers came from India and traced, Roclon that have been shipped to Ghana and came through the Indian embassy, and then they went to FDA and were able to, arrest a lot of, wholesalers and retailers, and then there are a lot of hospitals that were having that superiors, Roclon. We went and talked to them, so now they have pushed it aside and they are using the Roclon. Sometimes you may be deceived. So please, if you do not go in for the actual Roclon, you may put somebody life at risk. So please, M&G is the only agent for Roclon. So if you want M&G, you want Roclon for your patient, please come to M&G, and the reps for Baram Serum and vaccines are there, and they will attend to you. And that note, I'll say a big thank you for attentively listening to me, and I hope it's a good blessing. Thank you very much.
Good. Now our chairman will give his closing remarks.
Good afternoon. Please, shall we all clap for ourselves? Yeah, we deserve an applause because we kept awake and we listened with rapt attention all the presentations. And I'm so happy with the questions that came afterwards. Some people are saying some of the questions were not well answered. I said, don't worry, you are not alone. Even the chairman had questions that were not answered. Especially when it comes to these herbal medicines, I think we need to know more. We want to hear more. So we all had questions. And I think one good thing that we'll pick from this presentation is that I think the Ghana Health Service needs to do more, because they have established a herbal, a traditional medicine department in all hospitals. So when you go to the hospital, you decide whether you want the normal, what we do, or you want to do the herbal medicine. So if we are having all these discussions and we think it is good, why not? People should choose that option And then we can do some follow-up studies to see. That is where Dr. Odoejako's question comes in. You said, because when it is God, we want to remove, God is a confounding factor here. Because God is everywhere. But if you say your own is God, God will intervene. The other one to say, God will intervene. So when we have the two arms, those who accept to do herbal medicine, those who accept to do, medimosis medicine, then we can see what happens in 5 years, in 10 years. Then we can have the scientific presentations. That will help us. Again, thank you all for coming. We have more questions than answers because they are not here. I was just looking around, I see that they are not here. I'm sure they are still discussing the questions behind us. Thank you very much for this opportunity. Thank you.
And thank you, Mr. Chairman. Now, a few announcements. From here, you go to the poolside for a cocktail. There will be a council meeting at 7 p.m. Please be punctual because there's a game that you must watch. So council meeting at 7 p.m. Be punctual. Tomorrow will be heavy. We are expecting the Minister of Health himself. Registration will start at 8 a.m. The restaurant opens at 7 a.m., so try and go and eat your breakfast early so you can register for tomorrow's hectic event. Thank you all. We have closed.